So, sir, it's 3, 2, 1. So, over to you. We are live to the attendance.
Okay. Good morning, everyone. So
Morning, sir.
today again we are here on second Sunday of the month of May 2026 with another episode of FOGSI ICOG PG Clinic. And at the outset, we are grateful for continuous support for continuation of this program. And we especially thanks our FOGSI President Dr. Bhaskar Paul, FOGSI ICOG Chairperson Dr. Sheila Mane, and all the office bearer of ICOG and Secretary General Dr. Swarna Khadilkar. With their continuous support and coordination and guidance, we are running into the fifth year of this program. And as you know, this program is every second Sunday of the month at 11:30 a.m. And the recording of the program is always there available on the website. You have to go into the archives to see the old recording, and current recordings are available in the current website page. So please take advantage of those recordings, and you can revisit the topics at your will and at your convenience. So today's program, we are here with the again with the same format. We will start with the doll and pelvis, and there Dr. Ganpat Sawant will be teaching us about sutures, diameter, pelvic planes, and what is happening in normal labor. Then we have a case discussion, interesting case of PCOD with hirsutism. And SN Medical College Agra students are there with us, Dr. Ekta Gautam, Dr. Monica Chaudhary, under the able guidance of their teachers, Dr. Sikha Singh, who is the HOD of SN Medical College Agra, and Dr. Anu Pathak. She is professor at Agra Medical College. And we have esteemed teacher faculties with us, Dr. Renu Gupta from Kanpur, Dr. Bhavani Pegu from Jipmer, Pondicherry, Dr. Rajashri Kane Singh Gupta from Datta Medical College, Nagpur, Dr. Ananya Das from Shillong, Nigrims. So, and Dr. Ashish Mukhopadhyay as usual with us. So you can see we have teachers from different parts of the country and different medical college. We can have, you can see from uh, Kanpur to Puducherry, and then Meghalaya, Shillong to Nagpur, Maharashtra. So the idea is to have exposure of all our students to various type of approaches, various teachers, so that they can understand the variation in the teachers also, and they can understand the way the a problem or a issue is handled by the teachers. So this is very important to understand, because as you know, our students may have their examination centers in different part of the country. So it is a good practice to make them understand beforehand what is happening in the exam. And we have described it multiple times that our examination pattern is that we do terminal assessment at the end of 3 years, and only once the student get the opportunity to appear in the exam for final assessment. So these platform provides them a opportunity to learn that what is supposed to be there in the examination center, what they will be exposed to, and what they are expected to do in the examination center. So these type of practices help in development of the student per se, as well as we incorporate some skill based learning also. And in the skill based learning today, we have uh, we will be demonstrating how viva voce of the obstetric specimen is conducted in the exam, and what you are supposed to follow. And Dr. J.B. Sharma is a very known teacher, and he will be describing and teaching you and giving you tips how to handle viva voce of the specimens. And in the end, we will have quiz on PCOD by our quiz committee chairperson, Dr. Archana Kumari. So this is the program outline today, and I will first of all, before handing over to Hafiz, thanks my coordinator, Dr. Ashish Mukhopadhyay, and Dr. Hafizur Rahman also for conducting this program, and our chairperson and secretary, our chairperson, Dr. Sheila Mane, and secretary, Dr. Pratik Tambe are with us, and I request both of them one by one to say a few words. Dr. Sheila Mane, madam, please.
Thank you, Dr. Ashok, and good morning to all of you. And Dr. Ashok has already explained about the today's program, and I thank all of you for accepting our invitation, and I welcome you all for this second Sunday PG program. Thank you, Dr. Shikha Singh and Dr. Anu Pathak, for being there as mentors for your postgraduates, as well as Dr. Babani, then Dr. Rajasi, and Dr. Renu Gupta, and Dr. Ananya Das. Thank you for being there for this PG program, as well as I think Dr. J.B. Sharma and Dr. Ganpat Sawant. Again, we have two senior professors with us, and I think today's case discussion is on a very important topic, as well as the quiz is there. So the idea is, I think, as the quiz is added, Dr. Ashok Kumar, which is a very good thing, because that gives the completion, like whatever is there will be discussed in the case, but again a revision, and which will be good for the students. So it is amalgamation of so many things, which is really good. And I know that we have all senior teachers here, Dr. Ashish, myself in ICOG currently as teachers, and we do see to it that the examination pattern, all the students get well versed with it. So thank you once again, and welcome. Thank you.
Dr. Pratik Tambe, sir.
I would like to welcome Dr. Parag Biniwale. I saw him logged in. So welcome, Dr. Parag.
Saloni, can you allow Dr. Parag, I think, to unmute, because that was a thing happening.
Yeah, yes, let me share the unmute request, sir.
Okay.
Yes, I have shared.
Dr. Pratik Tambe, sir, you are there?
Yeah, I'm here. Thank you very much, Hafizur, Dr. Ashok Kumar, sir, and the entire team for putting together a beautiful program. I'm sure all the postgraduate students will benefit immensely. This is a long-running series of the ICOG, which has been spearheaded by the people at the top. And I would like to place on record my gratitude to them for taking care of this on a Sunday afternoon, every second Sunday of the month. For the past 5 years, they've diligently given their time, their effort, put a lot of hard work into bringing teachers from different parts of the country together so that the students benefit. Thank you very much for all your hard work and your efforts. And I wish all of you all the very best always. Thank you.
Yeah. Thank you so much, sir. So thank you so much, Dr. Sheila Mane, madam, for continuously allowing us this program to run these sessions. I would
Dr.
like
Hafiz,
to yes,
just
sir.
1 minute. We request Dr. Parag Biniwale
Yes, sir.
to say a few words.
I was requesting Dr.
Thank
Parag,
you,
sir.
Ashok. Let's carry on with the program. I'm just here
Okay.
to listen to the program. That's it.
Yes,
All
okay.
the
Thank
best
you.
to the students. Yeah, thank you.
Okay.
Thank you, sir.
Yes, Dr. Hafiz, you can start now.
Yes, sir. Thank you so much, sir. I think we are thankful to all the past presidents, the FOGSI team, as well as the previous ICOG chairpersons, and the current chairperson, Madam Sheila Mane, and the secretary ICOG, Dr. Pratik Tambe, and of course Ashok sir, Dr. Ashish Mukhopadhyay is always there for this program, and we are doing in 5th year. So we'll not waste any much further time. I'll straightly start the first session, that is unlocking the different areas of the doll and dummy, the skull as well. So I'd like to request for the first session, Dr. Ganpat Sawant sir. He is a former HOD and a senior professor at DY Patil Medical College, Navi Mumbai. So I would like to request sir to start his first session. Dr. Ganpat Sawant sir, over to you for the session 1. for your demonstration.
Okay, good morning, everyone. Thank you very much, Dr. Hafiz, and all the office bearers of ICOG. Let me start with my favorite topic, that's the pelvis, skull, and mechanism of labor. Dr. Hafiz, you have to guide me if I go out of the screen or something. And as per your demand, I'll be demonstrating with the pelvis, skull, and the doll, where we say it's a mummified fetus. And the third thing is there is a video in between. I just wanted to make it more interactive for or making things little lighter for the students. But anyway, I'll go ahead with this. Okay, coming to the pelvis, friends, please catch it in pelvis in a normal anatomical situation or position. Means basically anterior superior iliac spine and the pubic tubercle should be in one vertical line. What happens, most of the students, they catch it like this and they take it below the table in the lap. So the examiner has to peep in what is she or he is doing with it. So catch it in a normal anatomical position so that half job is done, because that means the examiner knows that you are catching the pelvis in a normal anatomical position. Now, as I have said in my video, but I'll tell you now without changing the video, in a day, usually we have 10 to 20 students, and it becomes really difficult for examiners to focus on each and every student. So you have to say something catchy. These are some of the lines we have taken from the Oxford. It says, "Good morning, sir. This is the pelvis." And the pelvis in Latin means the basin. It's something like a basin where weight of the body is transmitted into the lower limbs in standing position. Whereas when you are sitting down, basically your weight of the body is transmitted to the ischial tuberosities. Now, if you see these sentences, if you say these sentences, this examiner will say, wow, this boy is something really good. And they will start giving more focus onto this. So let's start with the pelvis. And this pelvis, if you catch the normal anatomical position, then you have to say something like this. Sir, this pelvis basically is divided into false pelvis, that is above the pelvic beam, and this is the pelvic beam, and below that it is basically called as a true pelvis. Now, why I'm saying this is because in exam, students usually start with, sir, this is the true pelvis, then outlet diameter, inlet diameter is not a good idea. So to make your thought process simple, what I will guide you as, say a few punchlines about the pelvis, give general introduction, then talk about false pelvis, then talk about true pelvis, and then go into the details of each part of it. When you're going into the details of each, focus more on the obstetric point of view rather than anatomical point of it. And as the time goes, I'll keep on giving more importance to the obstetric point of view. For example, some of the students will start giving development of basically iliac crest, development of pubic bone, and all other things, which we are not actually interested in the exam. So coming to, this is the pelvis, this is the gynecoid pelvis, and this is what its normal anatomical position is. Normal anatomical position I have explained it. With the pelvic beam, which basically starts from upper border of pubic symphysis, pubic crest, iliopectineal line, sacroiliac joint on one side, ala of the sacrum, sacral promontory, and same structures on other side. This will be called as pelvic beam, which makes angle of 55 to 60 degree with the horizontal. That's the angle which made with the horizontal, which is a normal anatomical position. So above this will be the false pelvis. False pelvis does not take part in a normal parturition except to support a pregnant uterus whenever it becomes abdominal organ. And that's why we do not give much importance to the false pelvis. So false pelvis, you see posteriorly it's the lumbar vertebrae, on either side is iliac fossa, on anteriorly anterior abdominal wall. So we just stop it here. Coming to the true pelvis or a proper obstetric part of the pelvis. So a true pelvis basically is nothing but which starts from pelvic brim and ends at pelvic outlet. So this is the part of the true pelvis or true canal through which the baby passes. And let's focus on this. So pelvis will be made up of basically two innominate bones, sacrum and the coccyx. Here I just want to say, which is there in my video, but today we are not playing. Pelvis is formed by four bones, joined by four joints. So my suggestion is don't say 4 or 5 as number, because in exam, during that tension, you might forget one of the joints or the name. And some examiners will be very particular. You said 4 joints. Which is the fourth joint? More than that, you just say it is formed by two innominate bone, sacrum and coccyx. All these bones are joined to each other by sacroiliac joint posterolaterally, pubic symphysis anteriorly, and sacrococcygeal joint posterior inferiorly. All these bones, when they join to each other, the inlet starts from the pelvic brim, which I had told you earlier, and outlet is basically from the lower border of pubic symphysis, pubic rami here on this side crest, ilioischial crest, sacrococcygeal ligaments, and the sacrum posteriorly. Now, what is to be discussed in the true pelvis is, first of all, as I said, it's a tunnel. But if you see this tunnel, it's very peculiar. What is peculiarity of the tunnel? Anterior wall is formed by pubic symphysis, which is just 4 to 5 centimeter in height, whereas posteriorly it is formed by 10 to 15 centimeters length, which is formed by this sacrum, and on either side it is formed by medial border of acetabulum, obturator foramen. Now, why I am stressing this? Because if you understand the normal labor, if you want to know the mechanism of normal labor, you need to know this architecture. And what is this architecture? Again, I'll say this wall is formed by 4 centimeters. So it's a tunnel whereby one side is only 4 centimeters, whereas other side of the tunnel is basically 10 to 15 centimeters. So we have to travel in such a way that one side is short, other side is too long. And that's where the baby has to travel. Within few minutes, you will come to know significance of this. So in this true cavity, we have to discuss following planes. So planes are plane of inlet. Then we have two important planes in the cavity. One at higher level is called as plane of greatest dimension. Plane at lower level is called as plane of least dimensions, and then outlet. So let's go into details of each one. Plane of inlet. As I said, a plane of inlet starts from, either you can start from posteriorly, that's a sacral promontory, ala of the sacrum, right sacroiliac joint, this iliopubic eminence, pubic crest, and the symphysis pubis, and same things on other side. Plane of inlet. Now at each plane, you will have to describe following diameters. For example, we have at the inlet anterior posterior diameter, transverse diameter, and oblique diameter. Students, those who are attending, please give attention. It sounds simple, but it's quite confusing. So let's talk about anterior posterior diameter. Now, when I say anterior posterior diameter in obstetrics, there is anatomical AP diameter and there is something called as obstetrical AP diameter. Anatomical AP diameter means basically between the two anatomical fixed points. So posteriorly, it's a sacral promontory. Anteriorly, it's a pubic symphysis. From pubic symphysis to the sacral promontory is anterior posterior diameter, which is roughly around 11.5 centimeters. There can be little bit variations in different books, but unfortunately, baby cannot make use of this anatomical diameter because there is a small projection on the posterior surface of pubic symphysis, and that's why this obstetrical AP diameter, or called as true conjugate, could be little shorter than the anatomical AP diameter. And this obstetric AP diameter will be shorter than the anatomical diameter. So naturally, if anatomical is 11.5, this is going to be around 11 centimeters. But in the body, this is difficult to measure, and that's why we do PV examination and try to reach the sacral promontory. And that's why we have a diagonal conjugate, which is from pubic symphysis to the lower border of pubic symphysis to the sacral promontory. And this is what is we measured with the PV, that is index finger, which is put in the vagina while doing PV examination. Roughly, if you minus 1.5 centimeters, you get obstetrical AP conjugate. So this is about the AP diameters of the inlet. Coming to the transverse diameters, transverse diameter is the widest transverse distance on the pelvic beam. Mind well, this is the widest transverse distance. It is not exactly in the center. It will keep on changing depending upon the type of the pelvis. So, widest transverse distance on the pelvic beam is a transverse diameter. Roughly, it is around 13 centimeters. And then we have this oblique one, which is if it starts from left sacroiliac joint to the opposite side iliopubic eminence, then it's called as left oblique diameter. Similarly, on the right side. And this is roughly around 12 centimeters. Now, if you, the students, those who are attending, if you analyze this, that is AP diameter is basically something around 12 or 11.5 centimeters. Transverse diameter is still bigger than the AP diameter. The shape of the inlet is going to be transversely oval. It's like an egg which is kept as transversely oval. So baby, while going into the pelvis, has to go in the transverse or in the oblique diameter, and that is what is we call as LOA, that is left occipital anterior, or either LOT, the left occipital transverse, and that's what the logic is. Okay, now come to the next plane, that is plane of greatest dimension, which usually in the middle of the posterior surface of the pubic symphysis to the junction of S2 and S3 posteriorly, and on either side is the medial border of acetabulum. And if we see diameters of this plane of greatest dimension, that's AP, transverse and oblique, all diameters are same. So naturally, the shape of this plane, that is plane of greatest dimension, is going to be circle. And that's why we do not give any importance to this plane. And that's the name also suggests plane of greatest dimensions. Coming to the next plane, which is a plane of least dimension, which starts from lower border of pubic symphysis on either side ischial spines and junction of S4 and S5. If you see this plane, again, the basically is AP diameter is longer than the bispinous diameter. That's the distance between the two ischial spines is definitely going to be a less. So, what is my point to tell you all this thing is, if they will ask a lot of things at the plane of least dimensions, what is the significance of plane of least dimensions? If you see what is coming into is the ischial spines which are jutting inside. So this is transversely, the distance is somewhere around 10 centimeters, whereas AP distance is definitely going to be more than 10, something like 11.5 centimeters. So what is the shape of this plane now? Transversely, it is less, anterior-posteriorly more. So the egg which was kept transversely, that is the head, baby's head, which was transversely while going in, at the plane of least dimension, it has to turn into AP directions. And that's the significance which you have to remember, to which I will come back again after some time. But next thing is they will talk about is, yes, doctor, what else you know about PLD, that is a plane of least dimension. And then here you have to keep in mind all the significant points related to PLD. Just to name a few, that is, this is a transversely narrowest plane, and that's what we call it as a bottleneck for the baby's head. This is the point from where the internal rotation of the baby's head starts taking place, origin of the levator ani, pudendal block, and then basically curvature of pudendal nerve and vessels. All these points you need to keep it in mind. And as far as the delivery of the baby, it's the station. If the baby's head or presenting part lies at this level, basically it will be station 0. If it is below that, then we call it as +1, +2, +3. That all of you know very well. If it's above, then basically it's a -1, -2, something like that. Okay, so that's about the plane of least dimension. Then come to the outlet or the plane of outlet. Now, plane of outlet, if you see it very carefully, is not in one plane. It's a lower border of pubic symphysis, ischial spines, and then at higher level is the sacral tip of the sacrum or tip of the coccyx. So it's a combination of urogenital triangle, where this is the base, that is the distance between the two ischial tuberosities, and this is anorectal triangle, where again the base is the same. So this is the rhomboid shaped area, plane of outlet. It's a combination of two triangular planes. Again, coming to the anteposterior diameter from lower border of pubic symphysis to tip of the coccyx, that's the anatomical epidiameter. And obstetrical one is from the lower border of pubic symphysis to basically a tip of the sacrum. Now, what is happening here is basically this is movable joint. This is a movable joint, so it doesn't matter much as the way we had a problem at inlet. So this is the movable. Transversely is again what we check by fish test is basically distance between the two ischial tuberosities. So it's basically outlet, and there's nothing much to talk about the outlet. What I want to say here from here is some of the points are angle of inclination made by the pelvic beam with the horizontal. And then if this angle is too steep, in which condition this angle can be too high? For example, when the sacral promontory lies at the L1, that's at the higher level, what we call as angle of inclination. So this angle of inclination will be very high. Whereas if the sacral promontory or the jutting portion lies at the level of S2, then basically it is be low inclination. And then both, if you compare both, then low inclination is definitely better as compared to high inclination. So this is just about the pelvis, pelvic inlet, cavity proper, and then outlet. Then some of these other things is curve of Keras. Now, if we joint the center point of plane of inlet, plane of greatest dimension, plane of least dimension, and plane of outlet, you get a J-shaped curve. And that J-shaped curve is nothing but the baby follows that path while delivering through the vaginal canal or through the pelvis. That is what is called as curve of Keras. Now, when I say it's J-shape, the J is formed at the level of ischial spine. That means baby's head comes downwards and backwards and then turns forward, comes downward and backwards, and this turning point is at the level of ischial spine, and then the head goes anteriorly. So this is what is some of the definitions about the pelvis. I'll just revise. Pelvis, say introduction, general head, something catchy lines by which examiner will be little bit more attentive. Then preferably don't say numbers about the bones and joints, say following. Then in that 5 minutes, you have to finish with the pelvis if it is given to you and if you are prepared. Then take pelvis in your hand, catch it in normal anatomical position, and then basically you go on describing the way which I described. Lastly, how do we classify this pelvis? And pelvis classification is commonly done by the method Caldwell and Molloy. These are the two gentlemen who described it, but they described it on the basis of shape of the inlet. So it is not a foolproof at all, because inlet it could be gynecoid, but outlet it could be android pelvis. And that's why Caldwell and Mola had described these different types of pelvises like gynecoid, which is typically seen in the females, android, which is basically nothing but in a male, typical male pig, then anthropoid, which is like an ape-like. So it's like an animal-like anthropoid pelvis. And lastly, which is a flat pelvis, that is anterior and the posterior. Whole thing has come together. That's a flat pelvis, which is commonly seen in rickets and osteomalacia patients. So this is about the pelvis. I think with this, I'll go to the skull and then finally few points about the mechanism of labor. And if the time permits, then we might play video also, how students they talk about it. Dr. Hafiz, so far is it okay? And Dr. Saloni?
It's perfect, sir. It's going perfect, sir. Please go ahead, sir. It's fine. You're perfectly visible as well as we can see the pelvis. Yes.
Thank you very much. Good.
Okay, sir.
Now come to the skull. What is happening in most of the medical colleges, either is a mutilated skull or a mutilated pelvis. All the joints may not be fixed, so it becomes really difficult. So you must practice in advance. And while practicing, the practice the way just now I am doing it, I am talking to myself only. So you can also do the same thing. In front of a mirror, you catch it and go on talking. But the best way is describe to your friends. When someone else is talking, it looks very easy. But when you start talking, it really becomes difficult. Okay, so come to this mummified fetal skull. Again, use the same logic. That is, don't immediately start describing, sir, this joint, this bone. No. What idea I gave you? Start with catchy line. Wish, good afternoon, sir. This is mummified fetal skull. This is the most commonest presentation or presenting part of the fetus. Most toughest part of the newborn child or the fetus. If the baby's head delivers, rest of the body is going to deliver in most of the cases, except shoulder dystocia, so that is different story. But unlike a breech, in breech we are always worried. In head, we are less worried. And that's some of the sentences if you say, you will be passing definitely. So I'll repeat. So this is mummified fetal skull. Most commonest presenting part or presentation of the fetus. Most toughest part of the newborn baby, as well as surface area is also more. So if the baby's head delivers, rest of the body is likely to deliver smoothly. This mummified skull is divided into vault and the base of the skull. Vault is formed by two frontal bones, two innominate bone, one occipital bone. I'll repeat. Vault of the skull, base of the skull. Vault is formed by membranous bones, whereas base is ossified at the time of the birth. Why? Because it has to protect vital structures in the brain stem. And that's why this is all ossified at the time of birth. These laid in membranes, whereas basically central part of the bone is more ossified than the peripheral part, it remains the membranous. And these bones, as I said, two frontal bones, two parietal bones, one occipital bone, and two temporal bones also. As I said, the junction of the bones, which are membranous, are called as sutures. And thus, in between two frontal bones, we have frontal suture. Two parietal bones, we have sagittal suture. Then between parietal bones and occipital bone, we have lamboid sutures, which are membranous structures, or these are moldable things. So these are the sutures, which is frontal suture line, sagittal suture line, and lamboid suture. Sutures, if you say sutures, then immediately, if possible, and if time permits, you can go on talking about significance of the sutures. Why they are membranous? Because so that it allows overlapping of the bone in case of normal labor also. Some amount of overlapping is normal. And this is given by us towards molding grades. And that's why grade 1, 2, 3, that you can read it afterwards. But grade 1 and 2 is definitely normal in cases of normal labor, so that when there's a compression by the pelvis, which we have studied, all the suture lines, they will start overlapping. The first suture line to get overlap is basically a sagittal suture line. And the grades is basically depending upon closing of the space, overlapping, and irreducible overlapping. That's how it. So if there is irreducible overlapping at the suture lines, then it becomes abnormal. This is a significance which you can detect in case of PV examinations. So these are the sutures. Now, if we have a sutures, which is sagittal suture, frontal suture, and the coronal suture, which I did not mention, but the suture line between the frontal bone and the parietal bone is called as coronal sutures. Now, when different suture lines they meet, then it's going to have a membranous area. So if we have this between the frontal suture, coronal suture, and the sagittal suture, four sutures, if they meet, is going to be quadrangular area, membranous area, what will be called as frontal or anterior frontanel, which is, look at this, is definitely a bigger area. If we have a junction of sagittal suture and a lamboid suture, that is going to be triangular. So significance is, if it is membrane filled area and quadrangular, it is anterior frontanel, whereas if it's small dimple and triangular, it's a posterior. So what is the significance? Because when the baby's head is very well flexed, you are likely to feel the triangular one, and that's why you need to know the anatomy and the significance. Anterior frontanel, if it's bulging, it could be hydrocephalus. There could be increased intracranial pressure. Post-delivery, if it is depressed, it could be dehydration. Anyway, that's a different part. But this has to close by 1.5 years, whereas this gets closed by 1.5 months or weeks. So this is what basically anterior frontanel and the posterior frontanel we are talking about. Now, what is the most important is, and now it becomes more complicated here, is different areas on a fetal head or a skull. For example, you have different areas on the pubis head, that is face, brow, and vertex, and occiput. Now, how to understand this? What I would like to say is, and you must know about this, because diameters, AP diameters will keep on changing depending upon the presenting part. So coming to this, face, for example, face is the presenting part, area bounded by supraorbital ridge, nasion or glabella, supraorbital ridge again, coming to the preauricular line, and submandibular area, that is here, submandibular area. So this is basically what is called as face is the presenting part. Face is the presenting part. Coming to the next is brow is nothing but area overlying the frontal bones. I'll tell you diameters in a short while. So this is a frontal presenting part, frontum, or it's called as sinciput. Then comes the occiput, or vertex. Vertex basically is the commonest presenting part, and you must know what is vertex means. So vertex is nothing but a quadrangular area bounded by anterior frontanel and the coronal sutures. On either side, two parallel lines passing through the parietal bosses or prominences, and posteriorly through the posterior frontanel or lamellate sutures. So it's a quadrangular area like this. Anterior frontanel, posterior frontanel, coronal suture anteriorly, and two parallel lines passing through the parietal eminences. Then area covering the occipital bone is the occipital. Now, if you know these areas, then while delivering the baby, we talk about one prominent point on that presenting part, what is called as denominator. So denominator is nothing but arbitrarily chosen fixed point on the presenting part. Presenting part is nothing but the part which is felt on per-vaginal examinations. Presenting part is the area which is felt in per-vaginal examinations. In that area, we have one prominence or the part which is spoken with respect to the maternal pelvis. So for face, we have chin, what is called as mentum. And that's how we say mento posterior, mento transverse, mento anterior. So these are the different face positions. Position again is nothing but the relationship of denominator with respect to the different quadrants of the maternal pelvis. That is what is called as position. Coming to the, what is this? Sinciput. We have prominence is frontum. So we say frontum, fronto-anterior or a frontum. Vertex is the presenting part, quadrangular, but denominator is not sitting here, but denominator is the occiput, is outside. And that's why we say occiput, left occipito-anterior is the position for the vertex. Vertex is the presenting part. So these are the different presenting parts. These are the denominators. And then we have diameters as usual. So we have a transverse diameters and then we have AP diameters. So transverse diameter is by parietal diameter, which is say around 8 to 8.5 centimeters. And AP diameter will keep on changing depending upon the flexion of the baby's head. And that I will explain you with the help of doll or the fetus. Before that, certain things you must know, and that is one, what are the changes which takes place in the fetal skull? And those changes are basically, one is cephal hematoma and second is caput succedaneum. Caput succedaneum is nothing but basically it's a temporary swelling on the baby's head, which is because of the constant pressure by the cervix or vacuum cup which is applied, which is the nothing but a collection of the lymph which is seen in the scalp, nothing to do with the bone. Cephal hematoma is basically trauma in instrumental delivery or a precipitate labor or some kind of trauma to the bone by which periosteal bleeding starts, and cephal hematoma will be always limited to the underlying bone. It will never cross a suture line. Whereas caput will be crossing the suture line. That's how you differentiate. Caput will take a long time to disappear. Caput succeeding will disappear soon. Kephal hematoma will take a little longer time. And for the details, we can read it afterwards. Coming to the last part, because we have got 10 more minutes, and that's nothing but this is the doll, which will be given in exam. Again, this doll will have either some limbs missing or something. And in exam, if they say, doctor, yes, please describe mechanism of labor, then you will be fumbling. So you should know how to catch it. So catch it in the proper way, how it lies in the normal or not position. So catch this all limbs together. Otherwise, one of the limbs starts coming out. This is all. You can tie it together, all those things with the membranes and start. Sir, I would like to describe mechanism of labor. Definition is mechanism of labor is nothing but a series of movement adopted by the fetus while passing through the maternal pelvis. So we have to see the series of movements. So sir, I would like to describe mechanism of labor for a singleton fetus in longitudinal lie, cephalic presentation, vertex being the presenting parts, baby being well flexed position. All contraindications for vaginal delivery are ruled out. And then I would like to describe mechanism of labor for a fetus who is in left occipital anterior position. So I did describe the left occipital anterior position means is the left occiput. Occiput is lying on the left side of the maternal pelvis. Now, please go back to a pelvis learning in the beginning. I told you at the inlet, it's transversely oval. So left occipital transverse or left occipital anterior. These are the only positions which are possible. Left occipital anterior. It is anterior posteriorly, it's very difficult. It is little, sounds impossible. So either it's a LOA or LOT. So with the constant pressure, constant uterine contractions, and bearing down efforts, the first thing which starts taking place and continuously takes place is descent. So main mechanism first and a constant mechanism is descent. Once descent takes place, when the biparietal diameter, that is biparietal diameter crosses the pelvic beam, head is said to be engaged. So second thing is head is getting, second mechanism is engagement. Once the head is engaged, there is resistance by the pelvic floor. There is resistance by the pelvic floor. So naturally, there is resistance from below, pressure from above. So there is a completion of flexion. So head is getting totally flex. So that's the third phenomenon. That's a completion of flexion. Uterine contractions are going on. Head is engaged in transverse or LOA position. There is a resistance from below, so completion of flexion. But still pressure is going on. Now, if you remember what I said, at the pelvic list diameter, is PLD, plane of least dimensions, anterior posterior diameter was more. That's the egg which was transversely, now it has become like this. And this is what the beginning of the internal rotation. So the next thing is internal rotation of the baby's head. Look at this. Baby's head has rotated internally. That is possible because AP diameter is more at the outlet as well as plane of least dimensions. By this time, shoulders have started going in. Now look at the shoulders. Shoulders transverse diameter is bisacromial diameter, which is gone in. It is gone in. And baby, if you remember again that line of true pelvis, anterior wall is only 4 centimeters. There's nothing for a baby to travel here. Posteriorly, baby has to travel like this. So baby's head is delivered by extension. So that's again you have to know. So first is descent, engagement, completion of flexion, internal rotation, then delivery of the baby's head by extension. This is how it is. Now what next what? Shoulders by this time, look at this. Shoulders by this time they have reached the plane of least dimensions. So shoulders bisacromial diameter will come in anterior posterior diameter of the plane of least dimension. So what has happened to baby's head now? Baby's head has turned to the left occipital transverse or on the left side completely, which is seen there as external rotation of the baby's head. So this is just baby's head has come out and then baby delivered by lateral flexion. So I'll just repeat in short. These are due to constant pressure, descent takes place. Constant pressure is because of uterine contractions, bearing down efforts, gravity, so many things. After this, baby's head, which is going in engagement. After engagement, there is resistance. So there's basically what is happening is completion of flexion. Once the completion of flexion, baby's head rotates internally, and then there is a twist at the neck. Baby's head delivers by the extension. Once the baby's head comes out, baby's head was forced to internally rotate. It comes back to normal, what is called as restitution. So it's restitution which is causing baby's head to come back to its LOA position. From here, basically, because our internal shoulders are getting rotated, which is seen outside as external rotation of the baby's head, rest of the body is delivered, and baby is handed over to the neonatologist. Coming to the last part, which I had told you, that diameters. When the baby's head is like this, plain simple, neither flexion nor extension, it's what I call as military attitude. So if it's a military attitude like this, occipitofrontal is the diameter. When it's well flexed head, it's very well flexed head. So it's basically nothing but suboccipitobregmatic. I hope you are able to understand. Suboccipitobregmatic. Now, suboccipitobregmatic is the in a well-flexed head, which is 9.5 centimeters, which can easily come out in a normal pelvis, gynecoid pelvis. Military attitude, neither flexion nor extension. Then comes deflexed head, something like, what is this portion? Brow or a frontum. That is the longest distance AP diameter, which is mento-vertical. Mento-vertical, I hope you are able to judge at least. And mento-vertical is basically the longest AP diameter where normal delivery is impossible. And the head is completely deflex. That becomes basically submento-bregmatic. Submento-bregmatic, where this is also 9.5 centimeters, and that's why normal vaginal delivery is possible. Details of face you can read, but mento-posterior delivery is impossible to happen because it's already stretched, but normal, safest vaginal delivery is possible in cases of face and well-flexed baby's head. Now, these are some of the conditions which I'll just summarize whatever I said because I'll stop in next 3-4 minutes. On the table, pelvis, skull, and mechanism of labor will be kept. Most of the students will start talking about the moment pelvis is given, sir, outlet is like this. Then they will come to inlet. Then they'll say, okay, epistem is given here. Then they'll say engagement is like this. Then you get lost. And that's why what I suggest is first say catchy line. 2, stick to your point and speak whatever you know the best rather than enumerating joints and bones and anatomy. I don't go into the details. Focus on pelvis. So false pelvis, true pelvis, division, something like that. You go ahead. At the end, you close it and catch it in above the table. Don't catch it in the lab because an examiner do not see it. So that's one point. If pelvis is kept on that side, jump out, don't jump to the other side and pick it up because then the examiner feels you have prepared only pelvis. So scan the table once you go there. Skull, Again, the same situation as I told you. When you talk about the skull or pelvis, whatever you say, same way your hand should move. Otherwise, you are showing face, talking about face, and your hand is on the vertex. That is hand-eye coordination. Sometimes you get lost. Fetus, have a look at the fetus. Make it a practice to catch a normal anatomical position because it looks, believe me, it looks simple, but when you start demonstrating, it really creates problem. And there, occipital anterior, it looks like occipital posterior. You say it's occipital anterior, but you demonstrate occipital posterior. So with this, I think I will stop, and this is 12:29. So 1 minute is for the comments. Thank you very much, Dr. Hafiz. You were coordinating with me for a long time. And thank you very much for this opportunity. Thank you.
Thank you so much, sir, for your excellent demonstrations. I think you have done complete justice to the topic as well as for the benefit of the student. It was an excellent demonstration, and I'm sure it will be lots of helpful for the students. And for the record of the things, I would like to tell that this recordings will be there in ICOG website. So the students can go later on, those who have missed it out or wants to see your demonstrations, they can go later on to the ICOG website and can access the benefits. So thank you so much for your excellent demonstration, sir. Dr. Ashok Kumar, sir, would you like to say anything, sir? Are you there?
So thank you, Dr. Pepper. It was excellent, though appears simple, but that high inclination and low inclination you beautifully explained, because most of, I remember our days Munrokers. In Munrokers, it was given very clearly that about inclination. So that was also very nicely explained. And also the attitude of the meters, which most of the time the students will not understand. But with the baby's head, you held it in that position and demonstrated. So it was excellent. Thank you.
Thank you.
You have demonstrated it was very spontaneous. I feel the student will feel it like easy and they can go and practice in their own pelvis. Thank you so much.
Thank you very much.
Dr. Ashok, sir, are you there? So if sir is not there, we would like to move on to the second session. This session on the case discussion, which have been there consistently there, and because case presentation is a very important part in the postgraduate examination. So for this session, I'd like to invite the students, Dr. Ekta Gautam. She is an dear postgraduate students, and they have been guided very nicely by their faculties. Dr. Shikha Singh, she is professor and head of SNMC, that is SN Medical College, Agra, and Dr. Anu Pathak, madam, she is professor of OBGYN at SNMC, Agra. We have a galaxy of expert faculties. Dr. Ashish Mukhopadhyay, sir, is there in a meeting, but he would like to join very soon. We have Dr. Renu Gupta, madam. She is professor and head at GSBM Medical College, Kanpur. So welcome, madam. Then we have Dr.
Hello.
We have Dr. Bhavani Pegu. So Dr. Bhavani is additional professor of OBGYN at Zipmar, Puducherry. We have Dr. Rajasi Kane Sengupta. She is professor and head at Datta Medical College, Nagpur. We have also Dr. Ananya Das. She is professor of OBGYN at Pilgrims, Shillong. So I'd like to invite all the faculties to take up the session. And at the same time, I'd like to invite the students, Dr. Ekta and Dr. Monica to please screen, and Dr. Ekta and Dr. Monica.
Good morning, ma'am and sir. Sir, I'm Ekta Gautam, junior resident 3.
So I'd like I'd like to request the faculties, Dr. Renu Gupta, Dr. Bhavani Pegu, Dr. Rajasi Kane, and Dr. Ananya Das, to take over and examine the students. Students, you can share your screen, and after introducing, you can start presenting. Over to all of you, the faculties, please.
Okay, sir. Thank you.
Good morning, ma'am and sir. I'm Dr. Ekta Gautam, Junior Resident 3, Department of Obstetrics and Gynecology from SN Medical College, Agra.
Good morning, ma'am and sir. I'm Dr. Monica, a third-year junior resident of Obs and Gynae Department in SNM Medical College, Agra.
You can start your case.
Yes, ma'am.
Ekta and Monica.
Monica.
You can't hear your voice.
Start the case.
Please unmute yourself.
Unmute.
Dr. Ekta.
Full screen and start your case.
Dr. Ekta and Monica, you are muted. Unmute yourself.
Saloni, the background team, can you check whether have you made them the co-host? Whether
Yes, sir. Yes, sir. Let me. I have shared the
You
unmute
check.
request to the Dr. Monica and
Should I have?
Ekta.
So we have unmuted us.
Sir, are we audible?
Yes,
Sir,
yes,
are we
you are
audible?
audible.
Okay. Good
Yeah,
morning.
please share screen again and you are audible.
Okay.
Please go ahead.
Yes.
Ma'am, I think your screen is stop share. It's not.
Ma'am,
Yeah,
is it
but-
visible now?
Yeah,
Yeah,
it's visible.
screen is visible.
Okay.
Yes.
Please go ahead after introducing yourself.
Ji. Good morning, ma'am and sir. I'm Dr. Ekta Gautam, third-year junior resident from Obs and Gynae Department, SN Medical College, Agra.
Good morning, ma'am and sir. I'm Dr. Monica, third-year junior resident of Department of Obstetrics and Gynecology of SN Medical College, Agra. I'm presenting a case of Miss X, 20-year-old unmarried female residing in Naiki Mandi, an urban area of Agra, which is 1 kilometer from SN Medical College, a second-year BSc student at Agra College, presented in OPD of Obstetrics and Gynecology Department of SN Medical College on 1st May 2026, with chief complaints of increased interval between menses since 2 years, increased hair growth on chin and jawline since 7 months, amenorrhea since 3 months. History of presenting illness. The patient came with a history of 3 months of amenorrhea. Her last menstrual period was 3 months back. Her cycles since 2 years are of interval of 50 to 60 days, lasting for 4 to 5 days, with heavy menstrual flow, using 5 to 6 baths per day, associated with occasional passage of clots and not associated with pain. She has also history of abnormal hair growth, mainly over chin and jawline since 7 months. She also complains about thinning of scalp hair since 7 months, which was insidious in onset and gradually progressive. She is giving history of weight gain of 7 kg over the past 2 years. She admits of not exercising regularly and her stressful life as she is preparing for some competitive exam. She affirms to the fact that she is sexually inactive. She is giving no history of fatigueness, cold insensitivity, constipation, and neck swelling. No history of deepening or hoarseness of voice and increased muscle mass. She is giving no history of palpitation, anxiety, and diarrhea. No history of galactorrhea, headache, and visual symptoms. She is giving no history of weight loss, fever, chronic cough, and night sweats. She has no history of any drug intake like oral contraceptive pills, antipsychotics, anti-epileptics, androgenic drugs, and steroids. Menstrual history. She attained her menarche at the age of 14 years. Her previous cycle are of interval of 28 to 30 days, lasting for 4 to 5 days, with average blood flow using 2 to 3 pads per day, associated with mild pain and not associated with passage of clots. Her cycles since past 2 years are of interval of 50 to 60 days, lasting for 5 to 6 days, associated with heavy blood flow, using 4 to 5 pads per day, associated with occasional passage of clots, and not associated with pain. Her last menstrual period was 28th of January 2026, that is 3 months back. Past history. She is giving history of increased duration between menses since 2 years. There is no history of diabetes mellitus, hypertension, asthma, or tuberculosis, or any surgeries and procedures. She is giving no history of allergy to any medication or diet, and no history of drug intake. Family history. Her father is a known case of diabetes mellitus type 2 since 15 years. No history of diabetes mellitus in her mother, and her mother has no menstrual irregularity. She is giving no history of any cancers on the maternal side of the family, like endometrial cancer or ovarian cancer. Socio-economic history. She belongs to lower middle class according to modified Kupuswamy scale. They are a family of 5 members. Her father is sole earning member with a monthly family income of 30,000. The per capita income is 6,000 per month. Personal history. Her appetite is normal. She is giving history of inadequate sleep of 4 to 5 hours per day since 1 year with frequent awakenings at night. Her bladder and bowel movements are regular. She is giving no history of any addiction like smoking or alcohol. Dietary history. She is taking non-vegetarian diet. Her estimated calorie intake per day was 2,200 kilocalorie per day, including 55 to 60% of carbohydrate, 5 to 10% of protein, 30 to 35% of fat. She is also giving history of intake of packed and processed foods more than 2 times a day.
So shall we move forward, sir?
Yes, please. Please move forward.
On general physical examination, the patient is well oriented to time, place, and person. The patient was examined in sitting position in adequate daylight with proper informed verbal consent. Her build was average and she was obese. Her height was 152 centimeters, weight was 74 kgs. Her BMI was 32 kg per meter square, which comes under category of obese class 2 according to Asian BMI classification. Her waist circumference was 83 centimeters. Her hip circumference was 99 centimeters. Her waist to hip ratio was 0.83. Pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema were absent. On head-to-toe examination, her skin was oily with no acne. Her hair growth was seen on chin, jawline, chest, and abdomen with mild hirsutism with a modified Ferryman-Galway score of 13. Acanthosis nigricans over the nape of the neck with Berkey scale of 3, and which was also seen on axilla and inner thigh. Breasts were normal. Her vital signs were pulse rate 82 per minute, BP was 112 by 76 mmHg, respiratory rate was 16 per minute, temperature was 98.6 degree Fahrenheit. Ma'am, we have shown how we have calculated the modified Ferryman-Galway score in our patient. So we have seen the hair growth on 9 areas. So when we saw on the upper lip, we saw small mustache at the outer margins, which led us to give her a score of 2. Then when we saw on the chin, there was scattered hair with small concentrations. On chest, circumareolar and midline hair were present, and on upper abdomen, streak of terminal hair was present in the midline. On lower abdomen, a few midline hair was seen. On the upper arms, scattered terminal hair was seen, which were covering less than 1/4 of the upper arm. And on the thigh, there was sparse hair growth covering less than 1/4 of the thigh. On the upper back, there was sparse terminal hair, and on the lower back, there was sacral tuft on the terminal hair. So when we have calculated the score, it came out to be 13, which comes under the category of mild hirsutism, according to modified Ferryman-Galvez score. On systemic examination, so on cardiovascular examination, S1 and S2 were heard. There was no murmur heard. On respiratory examination, normal vesicular breath sounds were heard. On per abdomen examination, so on inspection, shape and location of the umbilicus were normal. There were terminal hair growth seen on abdomen, and there were absence of any mass and scar. On palpation, there was no tenderness and there was no organomegaly. On percussion, there was nothing significant, and on auscultation, normal bowel and bowel sounds were heard. On local examination, pubic hair with the Tanner stage of 5 with adult female pattern, which was triangular in distribution, was seen. Her external genitalia appeared normal. Per speculum and per vaginal examination was not done in our case. Summary. A 20-year-old unmarried female from Naiki Mandi, Agra, an urban area of Agra, presented with chief complaints of irregular menstrual cycles for the past 2 years and amenorrhea for the last 3 months. She gave a history of delayed cycles occurring every 2 to 3 months, with menstrual bleeding lasting 6 to 7 days and soaking 5 to 6 pads per day, not associated with pain. She also complained of excessive hair growth over the chin and jawline, along with thinning of scalp hair over the crown region. On examination, her BMI was 32. Acanthosis nigricans was present over the nape of the neck and axilla. Coarse terminal hair was noted over the chin, jawline, and lower abdomen with a modified Ferryman-Galvez score of 13. These findings were suggestive of polycystic ovarian syndrome with clinical hyperandrogenism. Provisional diagnosis: Miss X, 20-year-old obese unmarried female with polycystic ovarian syndrome with mild hirsutism.
Okay, so nice presentation, Dr. Ekta and Dr. Monica. Can we please go back to the history, the first slide?
Yes.
Yes, the next slide. Next slide. Yes, so it all started somewhere 2 years back, right? With the irregularity of menses. And can you go to the menstrual chart?
Yes.
Yes, ma'am.
So here you see that she had some 50-60 days cycle since 2 years. And whenever she bled heavily. Now, can you tell me why she bled heavily?
Due
Why
to
was
chronic and ovulatory cycle, she has unopposed estrogen activity, which leads to heavy
So
menstrual.
that leads to what? Unopposed estrogen activity will lead to
endometrial hyperplasia.
proliferation, right?
Proliferation.
Yes,
Proliferation.
ma'am.
Proliferation. Yes.
Yes.
So now, regarding the hirsutism history, where you have detailed it out, please go to that page, hirsutism. Yes, so hirsutism is basically, you said, it started 7 months back, right? And the incidence was insidious and onset and gradually progressive. So in hirsutism, can there be some other way where the patient can present? Like, can it be rapid in onset and very intense? Can it be like that?
Yes, ma'am. It can be very rapid and very vigorous, ma'am, in cases of androgen-producing tumors.
Okay. So
Ovaries and
what
adrenal
are the
glands.
androgen-producing tumors you can think of?
Ma'am, they can be of ovarian, ovarian
Ovarian.
category and of adrenal. Ma'am, in ovarian tumors, they can be Leydig cell, Sertoli cells tumor, ma'am, adenoblastoma, which is
Okay.
called, and then ma'am, Leydig cell tumor. Ma'am, and in ovarian category, it could be adrenal. In adrenal category, it could be adrenal adenoma and adrenal carcinoma, ma'am.
Okay. Okay. Very good. Now, can I just ask something on the alopecia part?
Yes.
Yes.
So in alopecia, in PCOS, what type of alopecia you get? Where do we get the alopecia?
Ma'am, we see it in the
Over the crown area, ma'am.
Ma'am, on the frontal sides and in the temporal.
Temporal.
Ma'am, it is of male pattern alopecia.
Okay, and you also mentioned something on the competitive exam and she was stressed out and all that. So do
Yes.
you think that could also lead to alopecia? I mean, that could have contributed to alopecia
Yes,
Yes, ma'am. Yes, ma'am, it
due to
can.
her sedentary lifestyle.
because of increased cortisol, it can
Yes.
lead
ma'am.
to more androgen activity, right? So it
Yes.
might have contributed further to alopecia.
Yes,
Okay.
ma'am.
And acanthosis nigricans is something she had,
Yes,
and
ma'am.
you have graded it in Burt scale. So that is
Yes,
the
ma'am.
scale we have for acanthosis. Now, in that you said she is grade 3, right?
Yes, ma'am.
She is grade 3. So,
Yes.
can you tell me how the grade 3 acanthosis looks like? I mean,
Ma'am,
is it visible anteriorly when it's grade 3?
Yes, ma'am.
no, ma'am. It is seen anteriorly in grade 4, ma'am.
Ma'am, it is seen on the
Exactly.
neck region, extending to neck.
Yeah, it is extending laterally, but doesn't really show up anteriorly. Then it becomes grade 4.
Grade 4.
Okay.
Yes, ma'am.
Okay.
Okay, Dr.
Hmm.
Monica and Dr. Ekta,
Yes.
in your first slide, you have mentioned about the distance her home from the nearest healthcare facility, right?
Yes.
So
Yes.
it is mandatory, right? Mentioned in the case. So what do you think? Why is it important to have that information? Being a healthcare uh, provider.
And to see how near the nearest facility is. So is it feasible for her to seek medical help?
Okay, any other?
Yeah.
Ma'am, it helps in like if the college is nearer or the hospital is nearer, then she can come for follow up, which
Yes,
might be
yeah,
needed in this
it
case.
helps. Yes, it helps to access the medical care and the regular follow-up, right?
Follow-ups.
And the
Yes, ma'am.
emergency management and the
Yes.
treatment compliance. And
Yes.
delaying in diagnosis also can happen, and we can definitely see the financial burden because of the distance, right? So based on their healthcare facility distance from her home, it also help us to manage whether we can send the patient back to her home, or we can keep the patient with us as an indoor patient. Well, she may not compliance. If she won't come back, then it's a miss from our side, right? So it is important to know the distance from her home to the healthcare facility, right?
Yes.
Dr. Ekta,
Yes, ma'am.
very good presentation, both of you. I just wanted to ask one question. Your patient is showing all the criteria, which are the defining criteria as per Rotterdam's,
Yes.
right?
Yes,
So, can you tell me what are the challenges of diagnosing PCOS in an adolescent? Are the sonography criteria relevant and the same, or is there any difference we see when we are looking at an adolescent PCOS to label her as diagnose her as PCOS?
Ma'am, in adolescent cases, first of all, it is very difficult to differentiate between PCOS and normal pubertal changes that occur. Ma'am, and ultrasound changes, ma'am, they are not seen, or they are not included in the criteria for an adolescent PCOS patient, because their ovaries are already bulky, ma'am. Ma'am, so we do not use ultrasound criteria for adolescent patients. And ma'am, in adolescent patients, due to the pubertal changes, they already have acne. So it is very difficult to differentiate from PCOS and the normal pubertal changes. And ma'am, they already have menstrual irregularities in the first few years of menarche. So ma'am, that also is very challenging to differentiate between pubertal changes and the PCOS patients in adolescent age group.
Yes, so basically we don't rely only on the sonography because nowadays new scientific evidence tells us that sonography should be looked into as a diagnostic feature only after 8 years
8 years of
post
menarche, ma'am. Yes.
So before that, we have to look at the ovulatory dysfunction and hyperandrogenism.
Yes.
Okay.
Yes, ma'am.
Yes.
Yes, ma'am. Yes, ma'am.
Am I audible?
Just one sentence to add, Rajasi.
Yes. In
Just
your
one
case,
sentence to add, as
yes, ma'am.
good question you asked. And the so even if you find the changes like PCOS in adolescents, they are transitory.
Yes.
Okay, they will stay.
Yes,
So you will have to just
because of pubertal
lifestyle
changes.
modification.
Students, do you think obesity could also mimic PCOS? Maybe these changes which we are looking in this girl, maybe only because of her obesity and not true PCOS. Is it possible?
Ma'am,
Is
but
there any such phenomenon?
ma'am, obesity, ma'am, it can cause, ma'am, due to obesity, it can cause, ma'am, acanthosis, nights can occur. And ma'am,
And
menstrual
also
irregularities can also occur due to
due to
ma'am,
obesity.
ma'am.
Yes.
Yes.
Yes, it may mimic, but the
Yes.
criteria for defining and diagnosing are very well laid.
Yes, ma'am.
So you have to be very clear when you are looking at an obese PCOS.
Yes,
What are
ma'am.
the challenges we look at in management of obese PCOS versus lean PCOS? I mean, you please tell me in terms of investigations that you would request and also the specific treatments
Yes,
between
ma'am.
these two types of phenotypes.
Yes, ma'am. Ma'am, as she came to us with complaint of amenorrhea since 3 months, first we'll ask her to do urine pregnancy test to rule out pregnancy. Then, ma'am, we ask her to do a complete blood profile, that is hemoglobin or total leukocyte count and platelet count. And then we make her do her serum thyroid and serum prolactin, because they also can cause menstrual irregularity and weight gain.
And then, ma'am, we go for FSH and LH levels. And ma'am, we can go for androgen profile, in which we go for total serum testosterone levels and free testosterone levels. And ma'am, for blood sugar, ma'am, profile, then we go for fasting blood sugar and
2-hour oral glucose tolerance test and fasting insulin and HbA1c.
Yes. How does
Okay, ma'am.
how does hyperinsulinemia or hyperandrogenism affect your SHBG and testosterone profile? Biochemically, can you explain?
Ma'am, hyperinsulinemia,
it decreases the number of sex hormone binding globulins.
Yes.
So, ma'am, the free
Yes.
androgen level increases in the blood, ma'am.
Correct. So your total testosterone level will be higher, right?
Okay, so in line
ma'am.
with Dr. Rajesh's question, can I ask something? Like
Yes,
you said it affects, right? Ekta and Monica. Hello.
Yes, ma'am.
Yeah. So
Yes, ma'am.
now suppose the patient has already been on OCs, okay, oral contraceptive pills. She has come to you, and as you said, you have given her all the investigations. Would you still consider doing a serum testosterone when she is already on OCs?
Ma'am.
I hope I'm clear. Suppose
Yes,
the
ma'am.
patient is already on oral contraceptive pills because she had been having irregular menses, and then she lands up with you. And
Yes,
then,
ma'am.
as a part of your PCOS investigations, will you advise now serum testosterone for her?
Ma'am,
Yes, ma'am.
but
What's
it's
with the
No,
OCPs?
actually, what you do is you will not advise her now. You will give it a break of 3 months because your oral contraceptive pills will affect the level of testosterone, right?
yes,
So
ma'am.
you will do the test only after a period where she is off OCs for 3 months.
Yes, ma'am.
And
Okay,
it is
so
a good idea to test the androgens after like about 6 months of therapy, because most of the times that affects the hirsutism part. And if you are treating specifically for that with anti-androgens, say the T half of your hair follicles is somewhat around 6 months. So
Yes,
once you start her on hormonal treatment, you don't need to do repeated serum androgen, I mean testosterone levels, unless you're looking at something which is not fitting the picture, like maybe signs of viralization or like clitoromegaly or something like that, then only you need to do the repeat testing. Otherwise, as madam has said, you don't need to do, just follow her up for like 6 months and then decide the further course, therapeutic or reproductive goals.
yes.
actually, to diagnose hyperandrogenism in PCOS, when you have the clinical features evident, like you have hirsutism, alopecia, and all that here, then you really don't need to go for the biochemical evidence. It's only when
Very
it is very severe, okay, then you look for features of virilization. Can you tell me what is virilization? Is it something different from just hirsutism of PCOS? What is virilization?
Ma'am, it is a severe form of hyperandrogenism. Ma'am,
Yes.
it include features of like increased muscle mass, deepening and hoarseness of voice, and
Mm-hmm.
breast atrophy and
Clitoromegaly.
clitoromegaly,
I mean, it is
and
seen
Okay.
in
Okay.
cases of
Very good.
androgen producing ovarian and adrenal
Yeah.
tumors.
Yeah. That you already told. And
Yes.
you have put a negative history slide also, right?
Yes,
yes,
ma'am.
ma'am.
So that partly rules out most of the things. Of course, you'll be investigating again biochemical parameters. So can you tell me why did you look for weight loss, fever, chronic cough, night sweats to rule out
Ma'am,
which condition?
it is to rule out tuberculosis. And tuberculosis also causes endometritis, which can affect the ovulatory cycles in a patient, ma'am. And
You mean to say
tuberculosis is a very,
genital TB? Genital TB?
yes,
Yes,
ma'am.
ma'am.
Okay. Okay.
Ekta and hello,
in this
Yes, ma'am.
in
hello, Ekta and Monica.
Yes,
Yes,
ma'am.
Please, in the history slide, you can also take history about any psychological issues.
Yes,
yes,
ma'am.
To give history, ki she gained 7 kgs of weight in last 2 years. So have you
yes,
taken any history about eating disorders, any anxiety, depression? And she had been suffering from last 2 years, where she had reported to OPD after 2 years. So what brought her to OPD now? She may be concerned about her body image now. So that should also be included in the history.
Yes, ma'am.
And on the basis of scan, what else your radiologist should know when he is commenting on PCO morphology? Usually must have seen that many patients bring ultrasound report. Everybody is documenting PCOS.
yes,
Okay? Most
yes,
of the adolescents or adults who come to us, if they have a scan, usually it is documented as PCOS. So what should the radiologist know to document PCOS? How many follicles on which section? Please elaborate on this.
Ma'am, there should be more than 20 follicles in
Yeah.
either ovary of 2 to 9 mm, uh, with increased ovarian volume of more than 10 cc, with increased ovarian stromal ecogenicity.
And also, if the machine, ultrasound machine is not advanced, then the radiologist can see follicular per section,
And
and
per
they
section should be
also
more than 8
more than
yes,
10. So
follicles.
see, if the counts and the number should match, only then they should document, and the ovarian volume in 3 dimension, then only they should document it as polycystic ovaries instead of
Yes,
documenting every scan as polycystic.
polycystic.
yes, ma'am. Ma'am, follicles number per section should be greater than
8.
Yes,
8.
both should be taken.
Yes,
Yes,
ma'am.
ma'am.
So when we look at her history, we get to see that she is having inadequate sleep. Diet is also not proper. She has been gaining weight, and
Yes.
mostly it's like looks like she's adopting a sedentary habit, right? She's
Yes,
sitting
ma'am.
for exams, stressful and all that.
Yes.
So, do you think there's a lot we can do? I mean, there's a lot of scope for the lifestyle modification to come in here.
Yes, ma'am. Yes, ma'am. There is a lot of scope of lifestyle modification in our patient. Ma'am,
Yes.
we have advised her for dietary modifications and then for physical exercises. And for dietary modification, we have advised her to decrease her energy intake and to decrease her total calorie intakes, ma'am, to around 500 to 750 kilocalories per day. Ma'am, we have advised her to eat, ma'am,
Low glycemic index
index food,
foods and high protein
No
and
processed
high
food,
dietary
right?
rich.
No processed food.
Low
And
processed.
yeah, so she is preparing for exams and all. Now, if you tell her you exercise, and because she obviously won't like to spend more time on exercise, rather she would prefer to sit down and read, right? So,
Yes, ma'am.
how can you advise her in this? Say, these are very practical problems. I mean, you just cannot tell her to go to a gym or something. I mean, how will you advise her?
And we can
Her
advise to
exams
take
are nearing
stairs.
and has to take care of her health also. Can you tell
Yes,
me what practical points you will advise her on?
ma'am, we can advise to take stairs instead of lifts, and we can ma'am,
Very good.
advise her to go from your to go out where anywhere by bicycle, and ma'am, we can advise her 30 minutes of brisk walk, uh,
Yes,
30 minutes of brisk walk, 3 to 4 times a week.
and ma'am, she can walk down to her college and to her coaching center.
exactly.
Yes,
Yes, ma'am.
Exactly. So
yes,
these are certain things you can tell her even while studying. Sometimes maybe she can get up from her chair and take the book along and study. When she's attending a call, she might not sit and attend the call. So those are certain things. And what about the diet pattern? I mean, do you think for her, even counseling of the parents are also required? The whole family needs to take a healthy diet because, see, when the parents are taking samosas, you cannot tell her to take salads, right?
Yes,
yes,
So, how do you think you will counsel the parents also on that? Because parent education, parent counseling is also important here. It cannot be just her counseling.
yes,
yes,
ma'am.
So,
ma'am.
will you advise on the diet also?
Yes,
Yes,
ma'am.
ma'am.
And we have advised to take proper 3 meals in a day, which would
Okay.
include rotis, chapati,
Okay.
Salads
salad,
and fruits.
ma'am, a bowl of dal, and a mixed vegetable, ma'am. And to cut down the use of packaged food that they are having. Ma'am, they gave a history that they are having at least two
Two
times per
times per
day.
day.
They
Per
are,
day,
Packaged food.
that's too much.
yes, ma'am, that is too much.
Monica and Ekta, a little bit theoretical part. How do you define clinical and biochemical androgenism in PCOS?
Ma'am, clinical hyperandrogenism is excessive coarse terminal hair growth in females of male pattern distribution.
Yeah,
And
that is
ma'am, biochemical hyperandrogenemia is
and
when
clinical on other parts. Along with hyperhistiotism, what else do you find?
alopecia and acne.
Ma'am,
And
alopecia.
alopecia, female pattern hair loss, female alopecia and acne. And
Acne.
how do you define biochemical hypoandrogenism? And what are the tests you would like to do?
Yes, ma'am. Ma'am, biochemically it is called hyperandrogenemia. Ma'am, it is the increased androgen levels in the blood. And when serum free testosterone levels and total testosterone levels are increased in the blood. And we define it as hyperandrogenemia, ma'am, which comes under the biochemical marker. Ma'am,
Any index? Free androgen index. Can you elaborate free androgen index?
ma'am, free androgen index, it is, ma'am, the total, ma'am, testosterone in the body divided by sex hormone binding globulins into multiplied by, ma'am, 100. It gives a value of free androgen index, ma'am.
Achha, what is your comment on androstenedione and DHEAS? Those
Ma'am,
they should be done in every case.
DHEAS level, ma'am. Yes, ma'am. Ma'am, these levels, ma'am, they increase, ma'am, in cases of PCOS because, ma'am, androgen is produced by the ovaries and, ma'am, adrenal
Adrenal glands.
glands. These levels are increased, ma'am, in PCOS
If given a
patients.
choice to do LH-FSH level or serum testosterone, what would you like to do first in PCOS? If there are economic constraints, she is able to do only one test. What would you like to do, serum testosterone or LH-FSH ratio?
Ma'am, LH-FSH ratio.
LH-FSH ratio. So in this I disagree. I would like to do serum testosterone. What are the other experts? Please give your opinion.
Yeah, I think they should go for serum testosterone
Yes,
here.
I think that is a more
for
a
serum.
sensitive test. Yes, ma'am.
And which one will you consider? Serum, total testosterone, pre-testosterone, or FAI, androgen index?
Which is the best indicator?
Ekta, Monica, which one will you consider? Total testosterone or free?
Ma'am, free testosterone levels.
Okay, Ekta and Monica, you had a provisional diagnosis of PCOD. Now you have the investigation report which supporting your diagnosis, right? So
Yes,
before we go for any kind of intervention or counseling her towards more lifestyle modification, we have to have a proper counseling towards her. Why it's important to accept those modifications or the treatment. So being a young girl, she's only 20 years college going girl. So how will you counsel? What is the importance? What is the disease she is suffering from? So we have to make her understand and what can happen in near future. If she understands those consequences, then only she will adapt those lifestyle, right? So how will you counsel her for her near future?
Ma'am, we can tell her about the consequences that she can undergo. We will tell her about that she has to take care of her blood pressure and she has to take care of her blood sugar levels, ma'am, which can affect her in the future, ma'am. And she can also, we will also counsel her for doing lifestyle modification, which can affect her fertility in future when she gets married, ma'am. So we'll tell ki it is very important for her future and she can have very serious consequences, and she can also have cardiovascular risk, and ma'am, she can also have psychological effects.
Yes.
So we'll
Anxiety, depression.
So the important part
Yes.
of lifestyle modification advice, apart from diet and exercise, has to be sleep hygiene,
Yes,
number
ma'am.
of hours she sleeps. And secondly, a new problem we encounter these days is excessive screen time.
Yes,
It
ma'am.
has been shown to be an ED, an endocrine disruptor. So that also you should, it's very relevant to guide your patients, especially adolescents, regarding restraining of the screen time. About this case, कुछ कह रहे हैं मैम आप?
नहीं मैम, आप कंटिन्यू करिए.
Do you think there is any role of giving metformin to this patient apart from your lifestyle modification advice?
Yes, ma'am.
Would you give metformin to this girl?
Yes, ma'am.
Why so? Advantages. When will you start? Will you start it along with lifestyle changes, or will you wait? Will you put it in a stepwise?
And would metformin be the first choice, or you will consider something else?
No, ma'am.
Yes. Anything.
We can give her
Ma'am,
metformin.
Ma'am, our patient came with reports. She had seeked medical advice before also, but she was not at any treatment. But she had, ma'am, blood sugar levels which was, ma'am, impaired, which were in impaired categories, and ma'am, she also shows signs of acanthosis nigricans, ma'am, which
And signs of insulin resistance. So we can
ma'am, we
prescribe
should
her metformin.
metformin, which is an insulin sensitizer, ma'am.
So we know that hyperinsulinemia, insulin resistance, and hyperandrogenism are linked.
Yes,
now
ma'am.
there is this very good new molecule, a new kid on the block called semaglutide.
Yes,
Yes,
ma'am.
ma'am.
Of it, have you read about it?
Yes, ma'am.
Yes, ma'am.
Do you think it has any rationale for use in PCOS patients, like this obese PCOS patient?
Ma'am,
Yes, ma'am. It
it
helps in weight loss.
Yes, ma'am, weight reduction.
It has very specific indications. That is why I'm asking you. It is not to be given only for weight loss. What are the specific indications of semaglutide? For your patient, would it be indicated?
For impaired fasting insulin.
There is a particular cutoff of BMI which needs to be there.
What is the BMI of your patient? It's 32.
I'm 32.
So is she overweight, obese? Which class she belongs to?
I'm according to Asian BMI classification, she comes under obese category 2.
Yes, so semaglutide can be given for Asian obese BMI more than 30 in absence of cardiometabolic problems such as hypertension and diabetes. Between 25 to 27, if there is either diabetes or hypertension, type 2 diabetes or hypertension, then you are indicated to start it. Okay. And just a normal 25 BMI with no other comorbidities, semaglutide is not warranted. So for your patient, still today, the drug of choice for us would remain to be metformin. Can you give metformin to a PCOS?
Yes, ma'am.
What are the precautions when you give metformin?
It can cause GI upset like nausea, vomiting.
What,
So we
We
start.
advise her
when you
to
start
take.
metformin to avoid side effects, what are
Yes,
the
ma'am.
precautions you take to minimize the side effects of metformin?
And we advise the patient to take metformin during the bedtime, ma'am. And we give it and we titrate the dose over 1 to 2 weeks, and then, ma'am, we can give her in divided doses.
Yeah, we start with the very
Ma'am, we start with
500
500 mg
mg for 3 to 4
and we
days.
gradually escalate the dose, and
Yes,
we
ma'am.
advise her to take her after meals, and the extended release preparations are better to avoid side effects.
Side effects.
What are the side effects of metformin?
And nausea, vomiting, and diarrhea. Ma'am, it can cause on a long-term basis, it can cause vitamin B12
deficiency and lactic acidosis.
So lactase is a life-threatening condition, and you should always check vitamin B12 levels when you are giving metformin for a prolonged time.
Yes, ma'am.
Then vitamin B12 levels and LFT also should be checked if
yes,
you are giving metformin for a prolonged time.
Yes, ma'am.
Does metformin cause rebound weight gain? Does it reach a plateau and then patient starts losing sensitivity and then starts gaining weight again? Is such phenomenon known in literature?
I'm not sure.
Is the metformin indicated for lean PCOS patients?
Ma'am, ma'am, it is indicated in cases of, ma'am, obese patients, ma'am, and with patients with insulin resistance and patient not responding.
I'm asking for lean PCOS. With a little time back, you discussed about lean versus obese, right?
Yes,
we do get a phenotype which is lean but presents with all the symptoms of PCOS, and they are the challenges to us to treat. So, is it metformin indicated? Yes, it is indicated. Please do read about lean PCOS, okay?
Yes.
So can you tell me now the role of hormones in your patient? Will hormones help?
And which hormones are increased?
I mean,
Madam is asking about
combined oral
OCPs.
contraceptive pills in her?
No, she has irregular menstruation, all those things, right?
Yes,
so
yes,
whether
ma'am.
hormonal medication will
Yes, ma'am.
help her.
Yes, ma'am. We will give her fourth generation oral contraceptive pill, which has anti-androgenic activity or property. Example, drospirenone and cyproterone
So
acetate.
that will address which problems of her?
Ma'am, menstrual
Irregularity and
irregularities
hyperandrogen.
Yes, ma'am,
So
hirsutism.
both will be taken care of.
Yes, ma'am.
Yes, ma'am.
So can we go back to the differential diagnosis part? I mean, you need to rule out every other condition, right?
Yes, ma'am.
You have a slide on differential diagnosis?
Yes, ma'am.
Yes, ma'am.
Yeah.
Yes,
So can you tell me, like in congenital, why do you think it is not congenital adrenal hyperplasia?
And we have measured 17 hydroxyprogesterone, and if it is less than 200, then we rule out PCOD,
Then we
PCOS.
rule out congenital adrenal hyperplasia.
Okay, so 17 OHP, if it is raised, then it will rule out, right?
Yes, ma'am.
And for those androgen secreting tumors?
Ma'am, for these, ma'am, the testosterone levels will be very high, ma'am, more than 1, and the total total serum testosterone would be greater than 150 nanogram per ml. And it will be very
And
high.
the
Yes, ma'am.
adrenal tumors, which is more specific in adrenal tumors, which biomarker will you do?
DHEAS.
DHEAS will be more specific. And
Yes.
if you want to go for imaging, then in adrenal tumors, what imaging will you do?
Ma'am, we can go for ma'am, MRI, ultrasound, and CT scan of the abdomen to ma'am see the adrenal gland.
Yeah, so MRI is very specific for androgen secreting adrenal tumors. Okay, ultrasound of course will do, and for hypothyroid and hyper. So basically, what happens in PCOS when you have to write investigations, you have to write investigations to exclude certain other causes that also cause anovulation. Then you have to write certain investigations to assess complications. Like when you write TSH, prolactin, we write, right?
Yes.
For investigating a PCOS. So that is basically not to diagnose PCOS, but to exclude what?
Hypothyroidism.
Ma'am,
TSH
thyroid
is given to exclude
Yes, ma'am.
hypothyroidism, right?
Hypothyroidism. Yes.
And we give also serum prolactin.
Yes, ma'am.
Yes,
We go for
ma'am.
ma'am
Serum prolactin.
Yes, ma'am.
Ma'am, to exclude
So that will be to exclude
hyperprolactinemia.
hyperprolactinemia. Now, what are the common symptoms your patient has and the patient with Cushing syndrome would also have?
Ma'am, obesity,
Ma'am, weight gain.
hirsutism, and ma'am, insulin resistance, ma'am, acanthosis nigricans, ma'am.
So how will you rule out now Cushing?
24-hour urinary cortisol level, ma'am.
Ma'am, are done to do.
Okay. So can it be again premature ovarian insufficiency as well? What will be the features in history? What will she complain of if it is POI?
Ma'am, she'll complain of menstrual irregularities, ma'am. Yes.
It's too early
Yes,
to.
Dr. Renu?
It's too early. She's just 20 years.
No, premature ovarian insufficiency remains a differential diagnosis here as well.
Yes. Anything below 35 years would be premature ovarian insufficiency by definition. So a serum FSH level would be warranted as a workup of
Yes,
only
serum FSH
That is what I was asking them.
Ma'am, it would be very high in these patients, ma'am. And ma'am,
She is also complaining of hot flushes and
hot flushes. Very good.
hot
From history, she would be complaining of hot flushes.
Yes.
And
Okay.
simultaneously, when you order your investigation, you should also check for metabolic diuresis. You should also get her glycemic status, either OGTT or HbA1c or fasting, and lipid profile should also be done in these.
Yes, ma'am. Yes,
It
ma'am.
should also be ordered when you are ordering investigations for PCOS. It should
Yes,
be for thyroid, for glycemic status, and for lipid profile. That should also be ordered.
Yes, ma'am.
Did you actually do a mental health assessment for her? Because this is very important.
Yes, ma'am.
Did you do a mental health assessment for her, for your patient?
When we asked her about
Anxiety,
Do you know any tool we can use for mental health assessment in such patients?
And there is a scale called PHQ.
9 questionnaire, right?
Yeah.
So you give you ask her and then you give her scoring. And if you feel that it is moderate to severe depression, of course, you'll have to send her to a psychiatrist.
Yes,
right? Because this
Yes,
is very common and you should keep in mind.
Yes, ma'am.
And so for the management of this patient, how would you go about? Can you just brief it now? I mean, just tell us how will you manage this patient?
And will
You
advise
have
her.
diagnosed her, you have done all the investigations. Achha, tell me one thing, would you consider AMH as a diagnostic marker?
Ma'am, as the features of hyperandrogenism are very evident, so ma'am, it is not the mandatory marker.
It just supports the diagnosis.
Ma'am,
It is
if
not.
there are no features of
Is AMH a diagnostic marker for PCOS?
Ma'am, it is not mandatory, but we can offer when there are no signs of hyperandrogenism, ma'am.
And irregular menstrual.
Then,
Because
ma'am, the
it,
values of
because in this condition you already have hyperandrogenism
Yes, ma'am.
and you also have anovulation, right? So
Irregular.
AMH is not a standalone diagnostic marker for PCOS.
Yes, ma'am.
It said that AMH is the surrogate marker for PCOS.
Yes.
It is known as
It is
surrogate
a
marker.
surrogate marker. Okay, so how will you go about managing this patient now? You
What
have
would
to
be the
break the
first line
news
and what
first.
would be the
You
second
have to
line?
break the news first, right? That
Yes,
she
Yes,
has
ma'am.
PCOS. Yes, start
Yes.
from there.
Yes, ma'am. We'll tell her that she has PCOS, and then we'll counsel her and we'll advise her lifestyle modification about diet and ma'am exercising regularly. And then, ma'am, we'll give her progesterone, ma'am. We'll give her withdrawal, ma'am, because she is having 3 months of amenorrhea. And
Which is
first,
our primary concern. So we'll give her progesterone withdrawal.
ma'am, after that, we can keep the patient on oral contraceptive pills which contain fourth generation progesterones, ma'am. Ma'am, in our patient, we can start
Also,
her
metformin.
with metformin also, ma'am.
Okay, what about the facial hairs she has already developed?
Cosmetic therapies
Will
would
that
like
go? Will that
No,
go
ma'am.
when you start hormones?
No,
And we
ma'am.
can advise her.
she had
Ma'am,
on
first,
jaw and chin, she had so many hairs. She's so worried about your hirsutism. So any
yes.
cosmetic therapies you would like to suggest her?
Ma'am, we can give her, ma'am, a variety of options. She can go for waxing to threading to laser hair removal to electrolysis, ma'am.
That would
She
improve
can,
improve her confidence, no?
Yes, ma'am.
yes,
To
ma'am.
boost her confidence.
Yes, ma'am.
Do these cosmetic methods help actually? What is their role? What is their significance?
Ma'am, first of all, they'll boost her confidence. And ma'am,
Yes.
there are two types of methods, ma'am. Ma'am,
Epilation or depilation. Ma'am, epilation will remove the hair follicle, the shaft with the root. And ma'am, in depilation, will only remove
the
hair
shaft.
from the surface.
Yes,
Okay, Ekta and Monica, suppose
Yes.
this girl has entered into her perimenopausal era. Now she has again having the anovulatory cycle, have prolonged bleeding, and she's become anemic. So how will you, she was a known case of PCOD, still having same symptoms. So how will you manage? Because she was on OCPs those days, right?
Yes,
so how
ma'am.
will you manage?
Ma'am, patients who have prior history of PCOS in their postmenopausal period or perimenopausal period, they are also treated like patients of PCOS, ma'am.
Will you continue giving combined oral contraceptive pill for perimenopausal women? Because we have to prevent her from being anemic, right? So it
Yes,
is
ma'am.
compromising her life.
Yes,
So
ma'am.
what will you do in this situation? We know that there are so many problem can arise. Endometrial hyperplasia. We really don't know whether she's started suffering from endometrial hyperplasia. So would you still like to keep giving the oral contraceptive pill?
Will advise her to use intrauterine devices like Mirena.
So before that, would you like to do something? Would you like to check something on her? If it's a persisting, definitely we have to look for the endometrial hyperplasia, whether she is having that or she is only having the anovulatory cycle alone. So based on that, we have to take the call, right?
Yes, ma'am.
Okay, can we just have some quick tips of learning from this case from you both? We'll wrap it up now. Just tell us some quick tips of learning from this case.
Yes. Ma'am, we can talk about the diagnosis, how we make the diagnosis. Ma'am, we use the Rotterdam criteria, modified Rotterdam criteria for the diagnosis of PCOS. Ma'am, which have 3 parameters, out of which 2 should be present to make the diagnosis of PCOS. The 3 criteria are, ma'am, first is menstrual irregularities or ovulatory dysfunction.
And the second is clinical or biochemical hyperandrogenism or hyperandrogenemia. And third is polycystic ovarian
ovarian morphology. Ma'am, And then, ma'am, yes.
In adolescent, again, we talked about it, right? Ultrasound, we have to be careful, putting it
Yes.
as a diagnostic criterion, right?
Yes,
So that
ma'am.
is also important.
Yes,
Then,
ma'am. Ma'am,
next,
then we come to the ma'am. We can talk about the treatment, and ma'am, we can also talk about the consequences of
Of
PCOS, ma'am,
the
in future,
risk
ma'am, that she
factors.
can have. The
The
patient.
infertility.
counseling is important.
Yes,
Counseling is
ma'am,
important.
very important.
Yes.
Lifestyle modification is important.
Yes,
Yes,
ma'am.
ma'am.
And relevant
Mental health issue
investigations
is
to be
important.
done. Okay, relevant investigations to be done.
Yes,
Yes,
ma'am.
ma'am.
Yes. And mental health issue is also
Mental
important,
health.
right?
We'll address the mental health, ma'am.
An investigation basically to diagnose PCOS, to rule out the other causes of anovulation, and to assess the metabolic complications. So, in those three headings, you have to think about giving her the investigations.
Yes, ma'am.
Okay?
Yes, ma'am.
What are the long-term problems of PCOS? Why are we actually worried about this specific class of adolescent PCOS? Because as it started, it was related to infertility always.
Yes,
We for the longest time we were looking at it from a infertile couple, ovulation induction, IVF that way. Now we are looking at adolescent PCOS and giving it an extremely important um, area in OBGY. Why so?
she's having risk of type 2 diabetes mellitus also, and risk for
Yes, a major chunk of her problems would be a cardiometabolic risk long
cardiometabolic.
term,
Yes, ma'am. Metabolic.
which includes not just diabetes, hypertension, it also includes liver disorders like NAFLD and NASH,
Yes,
which
ma'am.
are very important. And as madam just very rightly said, at perimenopause, you could show up with an endometrial cancer, endometrial hyperplasia.
Yes, ma'am.
So it affects her reproductive health and her overall health for a long time and in various manners. So
Yes,
it's
ma'am.
essential that we diagnose and treat it very aggressively and counsel her regarding lifestyle changes, especially the
And routine
adolescent.
and periodic metabolic screening in these patients to be advised always.
Yes.
I think we have covered almost all the aspects.
Yes.
And they have also presented well.
Yes, I
Yes,
congratulate
very well.
Monica and Ekta.
Yes, ma'am.
Thank you.
And
Yeah.
congratulations to
Nice, so
HOD
nice,
madam also.
nicely
Shikha madam also.
Confident
presented,
review.
and yes,
Thank you.
the
Shikha
credit
ma'am and
goes
Anu
to
ma'am
Nice
also.
discussion.
credit goes to the moderators.
Thank you. Thank you.
All the best for your exam, Suchi.
Thank you, ma'am.
Nice
Best
discussion.
wishes.
Yeah, all the best for exam.
Thank you, ma'am. Thank you, ma'am.
Thank you, Dr. Renu,
Thank you, ma'am.
and everybody. Yeah, thank you. I think Ekata and Monica.
Yes,
Yes,
Okay, thank you, ma'am.
thank you.
Thank you, ma'am.
Good afternoon.
Good afternoon.
Thank you.
So all are welcome to Bangalore for ICOG annual on 21st, 22nd, and 23rd.
Yes, ma'am. Looking
Okay.
forward.
Very nice. Dr. Renuji, आप भी आइए.
See, ma'am.
Okay, everybody. Okay, even Nuja. I think we have. We also have one more teacher was there, no? From anyway, all of you. Okay, please. Thank you. Hafizu, I think we have to move forward.
Yes, ma'am. I thank you so much. I'd like to sincerely thank the team of SNMC, Dr. Ekta and Dr. Manikas, the students, and as well as their faculties, Dr. Shikha Singh and Dr. Anu Pathak, madam, all of you, and all the faculties, Dr. Renu Gupta, madam, Dr. Bhavani Pego, Dr. Rajasi Kane, and Dr. Ananya Das. So we are sincerely thankful, and I am sure the students for the performance, faculties has given their comments. So thank you so much for all of your participation.
Okay, thank you, Steve. Thank you, Dr.
Dr. Ekta, can you stop sharing the screen? So, Dr. Zebi Sharma, sir, you are there, sir? So I'll just get back to Dr. Zevi Sharma, sir.
Dr. J.B. Sharma sir has not joined yet.
Yeah, sorry, I was having difficulty connecting from my own phone, so I'm joining using my assistant's phone. Thank you.
Saloni, can you share the screen?
Yeah.
So for this third session, I would like to request Dr. Zevi Sharma, sir. And Dr. Zevi Sharma is a former professor at AIIMS, New Delhi. And I'd like to invite you, sir, for these sessions. I am sure the students will be benefit from these sessions. So, sir is going to take specimen in obstetrics especially for the postgraduate students, and which is a very important because many of the time the postgraduate students are confused how they will start in this specimens, how will they start in the opening the mouth specimens, and they are scared. So, sir is going to make them easier and going to give them some useful tips. Over to you, sir. JB, sir.
Thank you. Thank you, Dr. Hafizur Rahman. It's a real pleasure to be here and interact with these students. So as Dr. Hafizur Rahman has said, specimens are extremely crucial. May it be MD exam, MRCOG, DNB, DGO, whatever exam. So there are specimens in obstetric specimen as well as gynae specimen. Okay, so that is why.
Just one submission.
Can we have the
I
next
thank,
slide,
sir, can I just say thank you to you? Dr.
thank you.
JB.
Yes, please. Thank you, Sheila ma'am.
Thank you for accepting to come on our online platform.
My
to
honor and
teach the
pleasure, madam.
students.
Can never say no to Sheila ma'am. Thank you.
Thank you so much.
Thank you. So, dear students, though this, so common specimens which are almost invariably asked. I have taken so many exams and that. So, H-mole specimen is very, very important, and you can get a H-mole, sometimes ultrasound picture also of the snowstorm pattern. But this specimen, you can see the H-mole here. So, it's the actual specimen of H-mole in which you can see abnormal trophoblastic proliferation with swollen chronic villi on histopath, here you can see the grape-like vesicles, and it's a complete mole. But it can be partial mole also. So if you can see the totally mole, only grape-like tissues in the whole of the specimen, then it is a complete mole. But if you see fetus also partly change into this hydropic degeneration, then we call it partial mole. So usually the specimen is mostly given in exam is complete mole. And the causes are usually abnormal fertilization causing chromosomal defects. So it's usually related to dispermia, etc. Symptoms of this, of course, are vaginal bleeding, excessive vomiting, enlarged uterus, because the excessive secretion of HCG is there. So that's why patients tend to have hyperemesis, and they can have even pre-onset preeclampsia even before 20 weeks of gestation. So if the diagnosis is like, if you do HCG levels, they're very high with HCG levels, and on ultrasound scan in the patient, snowstorm pattern is seen on ultrasound scan. So in management, usually we do like suction evacuation is done and arrange the unit of blood, and we then do the histopathological examination. The whole specimen is to be sent because really there may be choriocarcinoma. And of course, you need to read about the follow-up of the patient, that we need to do serial beta HCG monitoring to detect persistent GTD. And then ideally, they should avoid conception in 1 year for 1 year or so. And we need to follow these patients. So please do read. We don't have time to go into the complete history of H-mole choriocarcinoma, but that gives you the examiner opportunity to ask you questions. So basically, the specimen gives an idea how the viva flows. So they will ask you, what is this? You will say it's a specimen of H-mole. How does the patient manifest? You will see, amenorrhea, hyperemesis, and vaginal bleeding. How will you diagnose? What will you do? I'll do ultrasound scan and beta HCG level. Ultrasound scan will confirm the snowstorm pattern, and then beta HCG levels are not for diagnosis. No absolute values of beta HCG can tell us whether it is H-mole, normal pregnancy, twin pregnancy, choriocarcinoma, but that is important from point of view of follow-up of these patients. And then management is invariably suction evacuation. And then how do you follow these patients, and what can we do to prevent? All that can be asked from you. So that is a very common specimen asked in exam, and very easy to answer, easy to score good marks. Next slide, please. Can we have the next specimen, please? Yeah. Okay. So then you can have some specimens related to placenta. So in this case, you can say it's a double placenta. So placenta of DADC twin, diamniotic dichorionic. So you can see single placenta is there with two cords and two amniotic sacs are there, and diamniotic dichorionic pregnancy with two separate amniotic sacs and four membranes. If you see in the center one, there are four membranes, two corones and two amniones. Then the examiner can ask you how to diagnose it in antenatal period. So from there in DADC twin, you will have that twin peaks that twin peak sign, and in monoamniotic twin pregnancy, you will have one T sign. So that is important because in DADC twin the placenta has got thickness, four membranes are there, and sometimes the placental tissue also grows into it. That is what we call twin peak sign and or T sign. While in case of monoamniotic twin, it's a very thin membrane between the two, only amniotic. So then we have T sign in that case. That's how to differentiate about the placenta, and then they can ask you some other abnormalities of the placenta. Some rarely in exam you can get a placenta with chorioangioma, placenta with circumvallate placenta maybe we may be having, and then they can ask you what is the importance, how to diagnose. Like in twin pregnancy, they may ask you about twin pregnancy, other diagnosis, and then other like how to manage that patient like that. Next slide, please. Okay, so this is a case of specimen of Battledore placenta. So normally you would see the umbilical cord is attached to the center of the placenta, but in this case it is attached to the margin of the placenta. That's why I can call it a Battledore placenta. So part of the point of umbilical cord insertion into the placenta is usually eccentric and being a little one side of the center of placenta. When it is at the edge of the placenta, we call it Battledore placenta. And increased incidence of cord presentation and cord prolapse is there in this case. That is the significance of practical. So that is, and really it may be associated with the early division of the membrane, and so that can create problems. So this is the importance of it: increase in sense of cord presentation and cord prolapse. Next slide, please. Okay, so this is the filamentous insertion of cord. So normally, when the umbilical cord is attached, then it gets the branching occurs after its attachment to the placenta. But sometimes the branching occurs in the cord itself. Then we call it filamentous insertion of the cord. So this is associated with, and often it may be associated with Battledore placenta, the person which we just saw. In that case, the branching of vessel in the umbilical cord occurs in the umbilical cord itself before its attachment to the placenta. And it is called vasa previa if it is in lower segment. And its importance is that it can cause antepartum hemorrhage, which can be of fetal origin. That is significant. And how to differentiate, examiner may ask you between fetal blood and maternal blood is by test doing, for fetal blood cell, they are resistant to alkali. So you can do F test or, alkaline denaturation test. And the reason is that, even a small amount of blood, 10 to 20 ml blood loss of the fetal origin can cause fetal exsanguination. So that's why it's very important to know that it is fetal blood, and that will be an indication of immediate cesarean section, because the fetal exsanguination and fetal death can occur if not treated on time. So if filamentous insertion of the cord is associated with Battledore placenta and it is sometimes the lower segment of the uterus, then we call it vasa previa also. Patient can present with APH of fetal origin, which is a serious condition, and fetal distress exsanguination can happen. So we need to do immediate cesarean for them. Next slide, please. Okay. This is specimen of ectopic pregnancy. Actual self-injectment has been done. Sorry, the specimen looks a bit poor. So in this case, very simple. You can see a fallopian tube, and with it is red in color, and there is a blood clots, and you can sometimes see even the small fetus in that. So total self-injectement done after laparotomy or laparoscopy, and the fallopian tube is enlarged and congested. Its external surface is ruptured. The edges of the rent in tubal wall are irregular, shaggy, and a blood clot is adherent at that side. So that is how you can easily make out it's a ectopic. In actual specimen, the picture is a little hazy here, but can be very easily made. Really, you can get a picture of laparoscopic ectopic pregnancy. So you can get a picture of that laparoscope has been put in, and you can see a large distended tube with blood in it. And sometimes some blood may be coming out to the end of the fallopian tube. Then we can call it tubal abortion is occurring. And sometimes it might have given way. Then we can say tubal rupture has occurred, and you can see the blood clot inside the tube. So ectopic pregnancy. So the examiner may ask you how to diagnose ectopic pregnancy, how to manage it, medical management, expectant management, medical management, condition to be fulfilled for medical management, like that, and then ultimately surgical treatment and laparoscopic self-injecting when to do. And really, if the patient is hemodynamically unstable, even laparotomy may have to be done. So these will give you an opportunity to start a viva or discussion on a particular topic, like ectopic pregnancy here, HMOL there, like that. Next slide, please. Yeah. So now NN capsule. So this is a specimen very easy to diagnose and very commonly asked in exam. So there is absence of major portion of brain, skull, and scalp. You can see large eyes are there, but head part is missing just a little bit, and it is incompatible with life. So stillborn or dies soon after the birth, baby, and the eyes are protruding due to absence of cranial cord. So we call it, you can say, frog eye sign or Mickey Mouse sign. And prevention is by periconceptual folic acid. In case of low risk pregnancy, the prevention is by 400 to 500 microgram. But in case of if the patient had one history of pancreatitis or other spina bifida or other neurotube defect, then the dose is pharmacological. In those cases, you have to give 5 milligram, 4 to 5 milligram daily of the folic acid. That means 10 times more pharmacological dose. But in low risk patient, everyone should have 400 to 500 microgram. But high risk patient need to get the higher dose. So in this case, the examiner may ask you how to diagnose it in antenatal period. So when we are doing anti-NB scan, we can make a diagnosis of anencefali. So this is one of those anomalies which can be diagnosed in early second trimester or end of first trimester, and then so that we can easily do. It is an indication of termination of pregnancy because they are not salvageable. So we can do MTP early 12 to 13, 11 to 12 weeks rather than waiting till 20 weeks of level 2 scan. Other anomalies like cardiac anomalies are usually detected at 20 to 22 weeks of pregnancy. So that is the advantage. So you diagnose it by ultrasound scan and that confirm the diagnosis. At though other levels we can do, but they are not of that much important about that. And management is termination of pregnancy. If the patient comes to you late in like second trimester, third trimester, so this is an indication of going. I mean, there is no upper limit of termination of pregnancy for such. Even at 32 weeks, we do we do deliver the patient because the baby is not salvageable. And it's not compatible with life. So the examiner may ask you, so it's a common, and again, the prevention is by folic acid therapeutic dose. So that means 4 to 5 milligram a day. And next slide, please. So same with spina bifida, you can see here, this is a specimen. It's a neural tube defect and most common malformation. So there is a failure of dorsal fusion associated with failure of full development of one or more development of vertebrae. So most common site is lumbosacral area. But spina bifida occulta can also occur. The defect is not visible externally. And meningocele is when there is herniation of only dura into the sac. Meningomyelocele is then meninges, along with meninges, the spinal cord is also herniated. So that's why. So again, in the case of spina bifida, and in this case, along with spina bifida, probably even the head is also not properly formed. So the two can coexist. I mean, spina bifida with anencefali and all. So again, this is also a neural tube defect. This can also be prevented by periconceptual folic acid in the form dose of 4 to 5 milligram for these patients. And diagnosis again by ultrasound. It can also be diagnosed sometime early second trimester, 11 to 13 weeks of pregnancy. But sometimes the diagnosis may be delayed up to second trimester, like in 18 to 20 weeks level 2 scan. So either way, whenever we diagnose it, then termination of pregnancy usually is to be done for such cases. But mild spina bifida, I mean, we may continue the pregnancy also. Next slide, please. Okay, and then this is a specimen of rupture uterus. You can see the total uterus and lateral rupture is there. So full thickness tear of the uterine wall during pregnancy or labor. These factors are previous cesarean section, obstructed labor, injurious oxytocin use. In this case, the tear is lateral and going almost from upper segment to lower segment. So this is not uterine previous cesarean scar rupture, but it is a rupture of the obstructed labor. That usually is lateral and it's a more serious one. And in this case, that's why if there is a rupture of the previous cesarean scar, we can still salvage the uterus. We can just do suturing. But if it's a lateral tear, as in this case, usually it's difficult to salvage such uterus, and usually hysterectomy has to be done as in this case. So usually patient present with severe abdominal pain, bleeding, fetal distress, and shock. And to immediate, you have to immediate to arrange blood of the patient, hemodynamically make it stable, and take her to OT and do laparotomy. And usually, often baby has already died and is lying in the peritoneal cavity. And then, so you just deliver that, and then you try to save the uterus, so it's bleeding from the sides, and it's very difficult. So usually we have to do hysterectomy. Rarely, if it's a lower segment cesarean scar rupture, then definitely we can just, and in that case, fetus can also be salvaged in a lower segment. So in that case, we do like laparotomy and then open that area. Usually the fetus may be partially hanging out. So we can even save the fetus in case of partial dehiscence or lower segment. And then in that case, after delivery of the patient, the baby and placenta, then we can repair the uterus if it's not bleeding too much. So that can be salvaged, but a lateral tear obstructed labor rupture, as in this case, usually requires hysterectomy for the patient. So this is so because they can cause massive hemorrhage, fetal death, maternal shock, And diagnosis critical suspicion supported by laparoscopy finding and emergency laparotomy with uterine repair or hysterectomy. Usually for lateral tier obstructive labor, rupture hysterectomy is required, but lower segment we can do repair also. Adequate management of their shock is to be there, blood to be arranged, and take care of the patient. Next slide, please. So they can ask you an exam about causes of rupture uterus, what is the obstructive labor, abnormal presentation like that. Now, this is specimen of hydrocephalus. So in this case, there is excessive CSF accumulation is there, and it causes dilated fetal ventricle, you can say. So head is extremely large. In this case, it was almost more than 25 centimeter in this thing. And there is, the causes can be acute ductal stenosis, neurotube defects, infections, hemorrhage, or genetic defects. And diagnosis is usually in antenatal period by serial ultrasound scan. So antenatal ultrasound shows ventricles more than 10 mm. And fetal MRI can be done, which will show defects associated with CNS other anomalies. And there may be associated findings of, like, macrocephaly, spina bifida, polyhydramnios. So quite often, hydrocephalus can be associated with spina bifida or some other anomalies. And so management is serial scans and anomaly screening is to be done and genetic counseling. Usually, I mean, if you detect it until period, we discuss with the patient and all. So usually MTP is indicated for such patient, but if the hydrocephalus is mild to moderate and sometimes patient refuses for MTP, then we can continue the pregnancy also. But if the brain matter is very less and there is severe hydrocephalus, there is hardly any brain matter, then termination of pregnancy is usually indicated. But the many times the diagnosis is done late, like, patient, we detect it 20 level 2 scan was normal, and at 32 weeks, 34 weeks, patient manifest, and when we do ultrasound scan, we can see very large head there, hydrocephalus. So in those cases, then we can let them, deliver, we can terminate pregnancy at that time. But because it's a fully grown fetus at 34 weeks or so, so in that case, either under ultrasonic control, we can first, like, decompress the fetal head by putting a needle transabdominally under ultrasonic control. So we can basically put a needle in the fetal head. It can easily goes inside there under ultrasonic control per abdomen, and then we can drain the fluid from CSF fluid from the fetal head. Then it collapses. Or sometimes the patient may come to you, may manifest to you in labor, and in that case, if the fetal head is presenting, quite often they may be present with breech presentation because the head is bigger and it is accommodating the bigger upper fundus. But if it is cephalic presentation, patient is in labor, patient sometimes comes to you in the hospital at that level only. So in that case, we have to do ultrasound scan on them. Quite often what may have happened is that they may be uterine rupture. And then attendant and patient's BP goes down, she goes into shock. And the attendant may blame us that you did something, that's why it happened. No, patient was already having rupture uterus, but hydrocephalic head was pressing upon it and patient was not bleeding. The minute we remove the decompression, the patient starts pouring and goes into shock. So that is the importance of that. If this baby, or we can do, if the brain matter is there and the hydrocephalus is moderate also, then in that case it may make sense to do elective cesarean section on them. And later on, we shift the patient to the pediatrics and pediatric surgeons, and they may put VP shunt, which is endoscopic surgery depending on severity. That means a shunt can be passed from the fetal head to the chest, thorax, and abdomen of the baby, so that it goes into the peritoneal cavity. Otherwise, the patient comes to you with established labor in this thing, then we may do and head is big cephalic presentation, then we can do craniocentesis. That means we can put a needle there and decompress the fetal head. Once the fetal head is decompressed by that, and then usually the head is delivered and you can deliver them vaginally. That can be also done. And in case of if it's breech presentation, then it's difficult. So usually cesarean section is to be done. But sometimes through it may be associated with spina bifida also. So we can also puncture through the spina bifida hole, and head may be compressed by putting some instrument there which decompresses the head and this thing. So that is to be done. And again, it is a microcephaly, macrocephaly, hydrocephalus, anencephaly. All of these are basically neural tube defects, and the management remains in termination of pregnancy. And usually how to prevent in future is again by giving them periconceptual folic acid in therapeutic dose 4 to 5 milligram a day. So that is how we do it. So I think that was the last specimen. So in I can again reiterate here. So in obstetrics, basically, I mean, in gynae you have a lot of specimens like fibroid, uterus, so lot different types of ovarian cyst. HMOL can be there in gynae also, and plus other conditions also. But in obstetrics, I mean, mainly either we'll have an abnormal fetus in the form of anencaply, hydrocephalus, spina bifida, or some other. Really, you can get a specimen of omphalocele also. So in that case, you can see that abdominal wall has got this thing, and same way gastroschiasis. So you can make out in gastroschiasis just the margin, while in anencaply the center, like body is just the center of the mass. So then they can ask you about how to manage them and all. Those are not indication of termination of pregnancy, but if the patient manifests early and wishes, we can do also termination. So, but they are amenable to pediatric surgery treatment later on. So these are the various specimens. I mean, anencaply, hydrocephalus, spina bifida, and then uterine rupture specimen I have shown. Tubal rupture or ectopic tubal pregnancy specimen can be there of the fallopian tube, and then various types of placental abnormality. Like sometimes they can show you simple normal placenta, they can show large placenta, they can show you twin placenta. So.
So, Dr. JB, yes, thank you very much. You have done a very good job, and you have explained everything about the obstetric specimen. And let's discuss few things more about the specimen in the exam. Can you hear me, Dr. JB? Hello? Hello?
Yeah. Any
Can you hear
question?
me? Hello? Hello?
Yeah, we can hear you, Dr. Ashok.
So let's discuss. See, how should we approach once the examiner gives us the specimen? See, a specimen is mounted in a jar and everything. They give you in the exam. So how should we approach about the specimen? That is very important.
Yeah. Okay. Thank you, Dr. Ashok. That's a very good specimen. So in exam, the dear students, you have to say that it's a mounted specimen of a fetus with hydrocephalus. Okay, and then the examiner may ask you how did you diagnose, how to like antenatal diagnose this condition, how does the patient present, how to manage. So that is how the sequence of viva goes.
Yes, and it is important that students should take 1 minute or so to see it from all sides, up and down and all four sides, rotate the specimen, try to see from all the sides, and then make your opinion. And first describe the finding, what you are, if what is being visible to you. Because sometimes examiner asks you that what is this? They will not ask you the diagnosis. If they ask you the diagnosis, then straight away you say this is the hydrocephalus. But if something is different, the question is in different form, then you have to answer accordingly. And important is that you identify from all the four corner of the specimen. That is very important. Yes, Dr. JB?
Yeah, absolutely. Totally agree. Thank you, Dr. Ashok. Yeah, sometimes they ask you what is the diagnosis, then you can say, they say describe the specimen. Then you have to mention completely and you have to see all around for 1 minute, Dr. Ashok said. Like this hydrocephalus patient baby may have, if you examine the back of this baby, there may be spina bifida there. So which you would have missed otherwise if you didn't look at all sides. And especially in gynae specimen, quite often, like you see from a distance, it looks like a static specimen fibroid. But when you look posteriorly, there may be another fibroid sitting there, and there may be tube and ovary on the posterior side. So you would have missed them. So that's why, and examiner appreciated that you are examining, looking the specimen from all sides, and that someone has not told you the diagnosis. Otherwise, they may say someone must have told you that you just say hydrocephalus. That's it. No, that's not. You have to describe the specimen in 1 minute. It is a mounted specimen of a fetus showing hydrocephalus, and you spend a minute on examining it all around. Thank you, Dr. Suk. That is very, very good.
And one should also understand that see, these specimen which we give you in the exam, they are just the beginning of assessment of your knowledge, because Viva can go anywhere. See, as Dr. JP Sharma has given you some questions, they may not be asked. The examiner may ask you something else also. So these are the few questions from where the examiner will take you to another horizon or another platform to ask you something more, something in depth. So you should have a detailed knowledge, detailed information about the specimen, whatever is seen. Like if there is a specimen of fibroid, You may be asked anything on the earth about the fibroid.
Absolutely.
That is very so. So these are the just to start the conversation. You cannot predict that what examiner will ask you. If you answer quickly in few 2-3 minutes, I think you will have a good impression on the examiner. Otherwise, examiner will keep you asking and here and there, and they will deviate you from one topic to the another topic if you are not answering well. So it is very important that you concentrate, listen to the examiner carefully, whatever is being asked, describe the specimen properly, take your time, and then answer whatever is being asked, and be ready to answer different types of questions pertaining to specimen. Yes, JB?
Absolutely, fully agreed, totally. So it is just an opportunity. Basically, examiners don't come prepared what to ask in exam. The student come. So it is in your hand. You start the discussion and take the examiner toward the topics which you have read and which are your strong points. Like same way Dr. Shok said, a fibroid specimen. So you can say describe the specimen. It's a hysterectomy specimen, mounted specimen. There is a 8 into 8 centimeter fibroid which seem to be capsulated. There is no area of hemorrhage, no area of necrosis, no area of degeneration, and immediately stop. The examiner will ask you what are the different types of degeneration. Then you speak 1, 1, 2, 3, and red degeneration. What is red degeneration? So it is in your hand what you want the examiner to ask. So you take him through the topic which you have read very well. So this gives you an opportunity to start a discussion at Dr. Shok's side.
Yes. So I think Dr. JP Sharma, thank you very much for joining us today and giving a wonderful illustration of the specimens. Thank you very much. Dr. Hafiz, over to you.
Thank you, Dr. Shok, for the opportunity.
Thank you so much, sir. Thank you so much, sir, JB Sharma, sir, for your excellent demonstration. And I'm sure this will be helpful. And we are very thankful for taking for in spite of your busy schedule. Thank you so much, sir. So, thank you, sir. So now we are moving to our last session. There is one exciting session which we have added from the last 1 year or so. That is on the postgraduate quiz, and the topic we do is in the same where we had the case discussion. So for today's topic, it is polycystic ovarian diseases. Now this is the question. The quiz is led by the chairperson FOGSI quiz committee, Dr. Archana Kumari. Then we have Dr. Bhavna Tiwari. She is East Zone Quiz Committee Coordinator, and Dr. Himanshu Malakar is also FOGSI Quiz Committee. So I'd like to invite Dr. Archana Kumari. Dr. Archana, madam, are you there? Dr. Bhavna and Dr. Himanshu?
Good afternoon, sir. Archana ma'am, unfortunately, she will not be able to join because she's at Indore.
Fine, but Dr. Bhavna, it's over to you. It's please.
Can I share my screen?
Sure.
Is it visible, sir?
Yeah, it's visible. You just can give some time to all to them join and give them the instructions till they are joining.
Yes, sir. Thank you, sir. So welcome to the ICOG quiz for the PGs. Today's topic, as sir has already informed, it's on polycystic ovarian syndrome. And this is the Kahoot game pin. So you can enter through this and by Kahoot site from the Google directly. Please write your own name. Do not write short form because it gets difficult for us to decide who are the winners. And you have to just enter this game pin, that is 3228497. You can also scan the QR code which is available here and can directly enter through the code itself. So we shall wait for the participants to enter.
Minty.
So the game pin is 3228497 via Kahoot. We have many of the participants are already entered. We'll still wait for 5 more minutes to start. So 22 participants are already inside. Great. Really happy this time to see the enthusiastic participation, sir. Last time we had less number while I was conducting the E-Zone quiz. We already have 47 participants, so now we'll begin with the quiz. I hope all of you are ready. Will be a multiple choice question type quiz, and you have to select the one best answer. 20 seconds will be provided to you all, and the fastest finger first will also get higher points. So all the best to all the participants, and let's start. Three, two, one, and here we go. So the first question is, cysts of polycystic ovarian syndrome are formed by, is it failure of atretic follicles to undergo apoptosis, oocyte proliferation, multiple corpus lutea, or cystic degeneration of ovarian cortex? Here it ends, and most of you have got it correct. It's failure of atretic follicles to undergo apoptosis. 26 out of 48 participants got it correct. So let's move to the next one. Nirosha. Nirosha is on the top of the scoreboard, followed by Satakshi and Yukti. Next. All are associated with long-term morbidities of PCOS except cerebrovascular accident, ischemic heart disease, ovarian cancer, or endometrial cancer. Except which of these is not a morbidity associated with PCOS? Answers pouring in. Here we end it, and again 21 out of you got it correct. Ovarian cancer is not associated with long-term morbidity as a long-term morbidity of PCOS. Endometrial cancer is quite common. Ischemic heart disease, and these three are not common, but ovarian cancer is. Next, which OCP is most beneficial in case of PCOS patients with obesity and hyperandrogenic features? Ethinyl estradiol plus levonorgestrel, drospirenone acetate plus levonorgestrel, ethinyl estradiol with cyproterone acetate, and ethinyl estradiol with desogestrel. So you have obesity and you have hyperandrogenic features. Mind it, there is hyperandrogenism. So which one will you prefer? So the correct answer is cyproterone acetate containing OCPs will be preferred. 36 out of all the participants got it correct. Let's see the scoreboard. Dr. Monica is leading the scoreboard, closely followed by KB and Dr. Rupa. Next, rule of recommendation of 4 punctures per ovary with 40 watts for 4 seconds at a depth of 4 millimeter is known as Armour's rule, Levinthal's rule, Irving's rule, or none of the above. What is the name of this rule for ovarian drilling known as? Armour's, Irving's, Levinthal's, or none of the above? The correct answer, only 9 of you got it correct. Though Levinthal and Irving were instrumental in diagnosis of PCOS, but it's Armour's rule for the ovarian drilling, that is 4 punctures of 40 watts, 4 seconds, 4 millimeter depth. So the scoreboard, Tara Kanta is now on the topper of the scoreboard, followed by Monica and KB. Let's see the next. 24-year women with oligomenorrhea and hirsutism with elevated LH-FSH ratio, primary driver of ovarian androgen excess in PCOS. Increased adrenal Diaz production, insulin-mediated theca cell stimulation, increased aromatase activity in granulosa cells, or decreased GnRH pulse frequency. Oligomenorrhea, hirsutism, LH-FSH ratio is elevated. So what is the driver of ovarian androgen excess? What is the basic mechanism? Yes, the correct answer is insulin-mediated theca cell stimulation. There is hyperinsulinism and this results in theca cell stimulation, due to which there is excess of androgen production. This is the basic mechanism. So 15 out of the participants got it correct. Let's see. The scoreboard is still the same. Tarakanta has a streak with 3 correct answers in a row. Good going. Let's see. Next. As per recent updates, PCO morphology is defined by more than 12 follicles of 2 to 9 mm, more than 20 follicles of 2 to 9 mm, ovarian volume more than 8 ml, or stromal ecogenicity alone. What is the criteria as per the recent guidelines? Is it 12? Is it 20? Is it ovarian volume or stromal ecogenicity? So the correct answer, most of you got it correct, is yes, it is more than equal to 20 follicles, 2 to 9 millimeter. The scoreboard is more or less same. Up to 12 places, Dr. P is the highest climber. Good going, Dr. P. Try better. Next. Which is the earliest metabolic abnormality in PCOS? Impaired fasting glucose, dyslipidemia, insulin resistance, or elevated HbA1c? Which is the earliest metabolic abnormality? Earliest. Most of you got it correct. Yes, it's insulin resistance. The most early metabolic abnormality which appears is insulin resistance, which results in the vicious cycle. Let's see the scoreboard. Okay, Tarakanta is still leading, followed by Dr. Satakshi and Hiba Rizwan. Next. 8th question. Which hormone is typically normal or mildly elevated in PCOS? Is it testosterone, androstenedione, Diaz, or sex hormone binding globulin? Which is normal or mildly elevated? So is Diaz, 21 out of all the participants got it correct. It's almost equal division between androstenedione and Diaz. No, it's Diaz which is normal or mildly elevated in PCOS and is involved in the pathophysiology of PCOS. Next. Tarakanta followed by Hiba and Dr. Anu Pathak comes on the 3rd position. 5 participants has already reached the answer streak of 4. Great. Next. First line ovulation induction in PCOS as per the 2023 evidence-based guidelines is CC, letrozole, metformin, or gonadotropins. What will you prefer for ovulation induction in PCOS? First line drug. Which ovulation you will prefer? Yes, most of you got it correct. It's letrozole. Clomiphene citrate is not the first line drug. 19 of you answered as clomiphene citrate, but no. As per the guidelines and recent evidence-based practices also, in PCOS, we are using letrozole as the first line ovulation inducing drug in oral ovulation. Next. Almost the same scoreboard. Nirosha has climbed up to the 3rd position. Next. Which is true about lean PCOS? No insulin resistance, no metabolic risk, insulin resistance may still be present, or always normal androgen levels. What is true? There is no insulin resistance, there is no metabolic risk, the androgen levels are always normal, or insulin resistance may be present. Yes, most of you got it correct. Insulin resistance may still be present even though the patient is lean and thin. So in lean PCOS also, the basic mechanism of insulin resistance may be instrumental. Scoreboard almost same. Let's move ahead. Most sensitive marker for biochemical hyperandrogenism is total testosterone, free testosterone, LH, or Diaz. Which biochemical marker will you use for hyperandrogenism, for diagnosing biochemically hyperandrogenism? Which is most sensitive? Yes, the correct answer is free testosterone. We go for calculation of free testosterone index, and this is the most sensitive biochemical marker for hyperandrogenism. Let's see. The scoreboard, almost the same. Rehmat is back with an answer streak of 3. Well done, Rehmat. Keep trying. So next question. Diagnosis of PCOS in adolescents requires any two of the Rotterdam criteria. Ultrasound is mandatory. Both hyperandrogenism and ovulatory dysfunction must be present, or the AMH levels. How will you diagnose PCOS in adolescents? The correct answer is both hyperandrogenism and ovulatory dysfunction is required for diagnosing PCOS in adolescents. Next. Dr. Tarushi has climbed up to the top 5 position. Tarakanta is still maintaining the top position. Let's see. Preferred gonadotropin strategy in PCOS is high dose step down, low dose step up, single bolus dose, or random dosing. So using gonadotropin for stimulating the patient. So how will you proceed? Start with a high dose, then step down, low dose, then step up, single bolus, or random dosing. The correct answer, yes, it is low dose and then step up protocol. We start with a lower dose, 37.5 or so, and then we can go for chronic low dose protocol, step up every 4 to 5 days depending upon the response, and so on. Almost the same. KB has entered into top 5 position. Rest list remains the same. 14th question, minimum weight loss needed to restore ovulation. 2 to 3%, 5 to 10%, 15%, or 20%. What are the recent recommendations? What is the minimum weight loss recommended? Time up, and yes, 48 of you got it correct. It's 5 to 10% minimum weight loss is needed to restore ovulation in PCOS patients. Slight change. The third position is now held by Dr. Shatakshi, followed by Dr. Anu Pathak. Otherwise, the scoreboard remains the same. Let's see the next. Identify phenotype. The patient has regular cycle, PCOM, and increased androgens. Phenotype A, B, C, or D. Cycle is regular. Polycystic morphology is there on ultrasound, and the androgens are increased. So what is the phenotype? Yes, the correct answer is phenotype C, because the cycle is regular in this case, so it comes under category of phenotype C. The scoreboard is still led by Tarakanta and followed by Hiba and Dr. Shatakshi. With this, can I ask Dr. Himanshu sir to kindly take up the next question?
Yes, thank you, Bhavna ma'am. And good afternoon, everyone. So we'll continue with the 16th question. So the 16th question, which of the following cancers has an increased risk in women with PCOS? Is it cervical cancer, ovarian cancer, endometrial cancer, or the vulval cancer? So we have another 10 seconds left. And the correct answer is endometrial cancer. Most of you have answered it correctly. So let us see the scoreboard. Tarakanta is leading. So next question. Which of the following is diagnostic of primary amenorrhea requiring evaluation for PCOS? Is it no menses by age 13, no menses by age 14 with normal thelarchy, no menses by age 15 or more than 3 years after thelarchy, or no menses for 60 days in a 2-year post-menarche girl? So this is as per the latest recommendations of 2023. So the correct answer is no menses by age 15 or more than 3 years after thelarchy. So let us see the scoreboard. Any change is there or not? The scoreboard is more or less same. Tarakanta is leading. Next question. An adolescent girl has clinical features suggestive of PCOS but not fulfill diagnostic criteria. How to approach? So we'll label her as an increased risk and reassess later, or we'll just ignore her symptoms as physiological. We'll start lifelong therapy for PCOS, or we'll perform an ovarian drilling in that girl. What will be the correct answer? So another 2 seconds. And the correct answer is you will label as an increased risk and we'll assess her later after she attains a physiological maturity. And most of you have answered it correctly. So let us have a look at the scoreboard. Scoreboard is all same. Or top 5 people are the same. Next question. Free testosterone in PCOS is best estimated by which of the following? Your options are: we measure direct LH measurement, or free androgen index, or serum DHEA only, or is it AMH levels? So which one is the best test? So another 5 seconds. And the correct answer is free androgen level, and most of you have correctly answered it. Let us have a look at a scoreboard. Top 5 people are same. Tarakanta still leading. So the next question. In postmenopausal women, PCOS diagnosis is primarily based on, your options are current ultrasound finding alone, current hormonal profile alone, endometrial thickness, or historical features during reproductive age. So which one will we consider to diagnose PCOS in postmenopausal women? The correct answer is historical feature during reproductive age groups. Many of you have answered it correctly. The scoreboard, now the leading person is Hiba Rijwan. So let us have a look at the next question. So this is question 21. The most accurate and recommended test to assess glycemic status in PCOS is it OGTT, HbA1c, HOMA-IR, or is it FBS? Which one will be the most accurate test to detect, look for the glycemic status? This is as per 2023 guidelines. The correct answer is OGTT. 29 of you have correctly answered it. So let us see the scoreboard. Yes, the scoreboard has now changed. Anu Pathak is topping the list. Tarakanta is on 5th. So let us see, still 9 questions are left. So this is which question 22. Which of the following is an appropriate initial screening tool for obstructive sleep apnea in women with PCOS? Is it polysomnography? Is it MRI brain? Or is it a Berlin questionnaire? Or it's serum cortisol level? So which one we like to do as an initial screening test for obstructive sleep apnea? The correct answer is Berlin questionnaire. So initially we assess it with a questionnaire, and 28 of you have correctly answered it. So let us look at a scoreboard. Anu Pathak is still leading. Next question. Women with PCOS have higher prevalence of obstructive sleep apnea if they are obese. Second option is if only in postmenopausal women, independent of BMI. Fourth option is only if they have insulin resistance. So which statement is correct? Women with PCOS have higher prevalence of obstructive sleep apnea. Correct answer is it is independent of BMI. So 14 of them have correctly answered it. Mostly they have chosen only if they are obese. So let us see what is the scoreboard now. Anu Pathak is leading again. Monica is back. So next question. Women with PCOS have an increased risk of metabolic syndrome by, your options are, is it 1.2-fold, 1.5-fold, 1.9-fold, or is it 3-fold? Which one is the correct answer? You have another 10 seconds. 5 seconds. So let us have a look. It is 1.9-fold. The correct answer is 1.9-fold. Let us have a look at the scoreboard. Anu Pathak is leading. Some new names we can see. Okay, next question. This is question 25. The acronym SMART in behavioral goal setting in management of PCOS stands for specific, measurable, achievable, realistic, and timely. Simple, measurable, accurate, relevant, time-bound, specific, manageable, accurate, realistic, targeted, or is it strategic, measurable, achievable, relevant, and time? Which one is correct for SMART? So the answer is 1A, specific, measurable, achievable, realistic, timely. There is a tie between A and D. 17 of them have answered both. Okay, so let us look at the scoreboard. So again, Anu Pathak is leading. Tarakanta is back on the top 5. Next question. Fetal complications associated with maternal PCOS include macrosomia only, intrauterine growth restriction, neural tube defects, or is it congenital heart disease? So which one is correct? What complication can happen in the fetus if the mother has PCOS? You have 5 seconds. And the correct answer is IUGR. So many of you have answered macrosomia. Okay, so let us have a look at the scoreboard. Anu Pathak is leading, followed by Rahmat. Next question. This question 27. As per guidelines, the minimum transducer frequency for accurate measurement of ovarian morphology is 3 megahertz, 5 megahertz, 7 megahertz, or is it 8 megahertz? Which one is correct? We have 10 seconds more. 5 more seconds. Let us have a look at the answer. So the answer is 8 megahertz. 16 of you have correctly answered it. So let us have a look at the scoreboard. Anu Pathak is still leading, followed by Monica, and then we have Ekta Gautam. Okay, so next question. This is question 29. Sorry, 28. Which of the following yoga asanas is recommended in PCOS management? Is it handstand, or is it peacock pose, or is it butterfly pose, or is it crow pose? Which one will you advise your patients to have? Because yoga is playing a major role in PCOS nowadays. So the correct answer is the butterfly pose. So how many of you have answered it correctly? You have around 50 of you have answered it correctly. So let us have a look at the scoreboard. Anu Pathak is leading. KB is back in top 5. So the next question. This is question 29. Which enzyme inhibition by progestins in OCP reduce peripheral androgen activity in the skin? Is it aromatase, 5-alpha reductase, or is it 17-alpha hydroxylase, or is it desmolase? Which one? Which enzyme inhibition by progestins in OCP reduces peripheral androgen activity in the skin? So you have another 3 seconds. And let us have a look at the correct answer. It is 5-alpha reductase. Around 18 of you have correctly responded to it. So the next, the scoreboard. Anu Pathak is leading, followed by Rahmat. And we'll go to the last question of this quiz. That is quiz number 30. Question number 30. Which phenotype of PCOS is considered non-hyperandrogenic PCOS? Is it phenotype A, B, C, or D? So which one is a non-hyperandrogenic PCOS? So this is the last question of this session. And you have 5 seconds. So the correct answer is phenotype D, which is 31 of you have responded correctly. So now the scoreboard will reveal the winners. So on third position is Dr. Monica. Second is Rehmat. And first position is Dr. Anu Pathak. Congratulations to all. Now over to Bhavna ma'am.
Thank you, sir. So congratulations to all the winners. And it was a very enthusiastic participation this time, as I mentioned in the beginning also. And I thank Hafizur sir and entire ICOG team for giving us the opportunity to East Zone to conduct this quiz. And we were really happy to see the responses because most of the answers were correctly responded, especially some of the difficult ones were also very nicely attempted by the participants. And thank you once again on behalf of FOGSI Quiz Committee in absentia of Archana Madam. She is not, unfortunately could not be present today in this quiz. So let's keep quizzing. Thank you, sir. Over to Hafizur, sir.
Well done, both of you. Well
Thank
point.
you, FOGSI ICOG, for giving us this opportunity.
Congratulations. Yeah.
Thank you, ma'am. Thank you, ma'am. Hafizur, sir?
Thank you so much. Yes, ma'am. Sheila, ma'am. It was just interrupted.
Yeah. I just thank you.
So do we need to take the numbers of the winners? We have the names of the first 3 participants, winners. Dr. Anu Pathak, Dr. Rehmat, and Dr. Monica are the winners. So do we need to take their phone numbers also for the distribution of prizes or something like that, sir?
Yes. Yeah, please take their address as well as phone numbers.
Okay, ma'am. Are the participants still logged in? Can we have Dr. Anu Pathak, Dr. Rehmat, and Dr. Monica?
Ma'am, that will know at the end of the session, ma'am.
Okay, so you can provide the list of these 3 participants, the number, so that we can contact for the prize distribution.
Okay.
In Imagica.
Okay, ma'am.
Can you note the names? It's Dr. Anu Pathak, Dr. Rehmat, and Dr. Monica, first, second, and third.
Okay, Dr. Anu Pathak,
Dr. Rehmat, and Dr.
Rehmat.
Monica.
Okay.
This is the sequence. Anu Pathak is on first position, Dr. Rehmat is second, and Dr. Monica is third.
Okay. I will
Saloni
check
can, you can get their contact details from the registration information.
Yes, sir. If I will check if we have that attendance in detail also.
Yeah, please share the ICOG team with us so that we can send their.
Excuse me, Dr. Bhavna.
Yes, ma'am.
This quiz is only for PGs or for faculty also? Because I have participated in this. So if it is only for PGs, I am withdrawing from my position. Please take the rest.
Hafizur sir?
Yes, sir.
Sheila madam is there, madam can say on that. Yeah.
Ma'am, Sheila ma'am.
Please withdraw my participation.
Ma'am, we have no hard and fast rule. As of now, we don't know as such rule that others can participate or not. Usually it is open to all, but I think final take should
I
be
think
by Sheila Mane ma'am. If
Sheila ma'am is not there. Sheila ma'am, are you there? I think ma'am has left.
Sir,
anyway,
we have not given this rule, na?
Right, thank you. No, there is no such rule. Thank you.
This rule is not there.
We will go with like as usual, no? Madam, it's okay only. We are very, it's okay that is, and it's very good that you have participated. We just want to encourage to participate everyone in this, and it's good. Thank you so much. Please don't withdraw yourself. We will consider it like that. Yeah, thank you, Dr. Bhavna and the entire team of the quiz committee. And I would like to, at the same time, sincerely thank you, Dr. Ganpat sir, and the SNMC team, that is Agra team, for the students and their well participation. and as well as all the faculties, including the case presentation faculties and Dr. Zevi Sharma sir as well, and all the quiz conducting committee for your contribution for this today's academic program. Thank you so much. Saloni, you can stop recording.
Thank you so much, everyone, for joining today's session. So with that, we are closing this link. Thank you.